So good morning to all YouTube viewers. Let's start the meeting proper. First of all, I'd like to welcome Councillor Andrew Gravels, who has been recycled to join the meeting again as a member after some years when, Andrew, were you in fact the chairman of the meeting, Andrew?
I was chairman for a few years, yes I was.
Yes, so welcome again.
Yeah, thanks so much. Thanks everybody. Nice to see some old familiar faces. Thank you.
Do we have any apologies for absence?
We just have one apology, Chairman. Councillor Helen Molyneux. Okay. She sent her apologies this morning. Thank you.
Fine, thank you. Now, I've just got some procedure to go through. To speak at the meeting, can I ask that you raise the hand symbol on the bottom border of the screen? I think it's the third one from the right-hand side, which brings up participants, and then you put your electronic hand up. And then when you've spoken, you then press the lower the raised hand symbol, so we don't keep chasing you and asking if you want to speak. However, if for any reason you're unable to use the raised hand button, would you please attract my attention by raising your hand in front of your camera? Thank you. As I said earlier, the meeting will be live streamed via YouTube. And I have already notified everyone that the meeting is public. So, Joe, can we start the meeting? Which we've already done, haven't we? We're on YouTube.
Yes, we've started the meeting.
So we're rolling. So have we any apologies for absence? We've got one person. Does anyone wish to declare an interest in anything that we're going to talk about, pardon me, this morning? No hands have gone up. No? Thank you. Can we then go to item number 3, the minutes of the last meeting? Can we confirm the minutes of the meeting held on the 12th of January 2021? Martin, you need to say something.
Yeah, just on the minutes. Sorry, I don't have I've got so many screens open. I haven't got the minutes in front of me. But on the first item that is on the SWOST report, although we've got the PowerPoint presentation attached to these minutes, I think the minutes should record that we didn't actually see it at the meeting because if you remember, there was a technical hitch, and we simply had a verbal presentation. And I think at the end of it, we didn't just say that there would be regular updates. I think we actually said that the presentation of data was inadequate and that we should have a more detailed presentation of the proper data. For instance, comparing SWOST with neighbouring or comparable counties in performance data. And the PowerPoint presentation doesn't contain that. It contains very superficial data. And I think we ought to minute the fact that we asked for a follow-up of proper data. And I'm not sure we should, I mean, it's in your hands, Chair, and a different discussion, but I'm not sure we should have to wait till July for that, which is the reply I was given to the question I asked. I think we should have it immediately, actually.
Through the Chair, we passed on all your comments from the committee to SWOST. We have tried to arrange a follow-up presentation. The earliest we're looking at the moment, due to the pressures on the system, is July. But I think Becky will support me here in that we have tried to relay all messages from the committee. Stephanie Bonser from SWOST was at the meeting and noted your concerns and comments and requests for more data. So all the information has been forwarded, Martin. We can relay that information again, but we would know there was no way that we were going to get a presentation before the end of this of this council. I think, Becky, if you wanted to come in on that one, just to explain some of the work commitments.
But I think the minutes should reflect the conversation, though.
I can note
quite
that.
accurate at the moment.
That's a fair request, I think.
Okay, that's fine. I can elaborate on that.
Thank you very much. No one else has anything to raise about the minutes of the meeting? And if so, would someone like to confirm that they are a true and accurate record? Did everyone hear that? Can someone propose that the minutes are a true and thank you, Paul.
Subject to that amendment, yes.
Yes,
Yes,
indeed. Yes.
The amendment will be going in the minutes of this meeting, Martin, so as a correction as well. Okay.
Thank you, Paul. Would anyone care to second that? We've got some very slow arms this morning. Thank you, Terry. Thank you very much indeed.
Okay.
So those minutes are approved. And now we come on to public representations. We have two representations from members of the public. Those members are Bren McInerney and John Thurston. And they have up to 10 minutes maybe to totally have their say, but the representation actually has to take no longer than 3 minutes. So I'd like to ask Bren to crack off. Bren, please.
Thank you very much, Stephen, really. And I'm going to take it that the question has been sent, which Joe said to me, to everybody, so it's there for yourself. Three parts to the question, really. The first part is around communication. The second bit is about effective, and the third bit is actually around assurance. So I've received the response, and thank you for that response. Having looked through the response last night, because I received it yesterday, it's really good. It shows a lot of communication going out there, really. The one bit that I would offer as a thought back around that is just a little bit more in terms of of making sure actually is landing, i.e. that assurance, really. There is so much communication going out, I accept that and whatever, really, but I still pick up in the community. I did when we had a ethnic minority and COVID vaccine discussion with some of the communities, that one community group openly said, you know, in essence, we're not getting any of this. It is really difficult to get the communication out to everyone, and I think that's what we should all aspire to, really. So two things. First and foremost, thank you to everybody in the public sector, private sector, public and individuals that are working so hard in COVID, tirelessly, day after day after day. I have some more thoughts and whatever, but maybe I could just send them through to Becky, really. So thank you very much for the response, but just probably a little bit more on the triangulation and that assurance that is landing effectively across all our communities. Thank you, Chair.
Okay, thank you, Bren. And now, Mr. John Thurston. I hear an echo.
Can you hear me? Yes, good. All clear?
Yes, crack on.
Right. Chairman, thank you for allowing the question, and also thank you to the local health authorities for their leadership, which make me doubly pleased to be living here in Gloucestershire. Also, thank you for the response to the written question, which has revealed there is indeed, I believe, a hitch in the strategy that was formulated 4 or 5 years ago to provide a new single hospital with 3 new health hubs to replace the 2 effective but ageing community hospitals. 1 hub is built and commissioned near to the new hospital. 1 is in progress, but the one in the rapidly expanding Lydney in the South Forest is still many years away, and will be certainly years after the new hospital is commissioned. The response to Para 4 indicates that the medical help will be provided by GPs, but in the words of the response, as GP practices are run as independent businesses. The decision on the funding and the timeline for this sits predominantly with the GPs in the district. Therefore, we're unable to commit. I'm asking, is it fair to expect good medical doctors to plan, run and fund a business at this scale now or when the population is expanded in 2025 and the future? Also, there is a hole in the response to question 5. We are urgently asking that the current much appreciated urgent care, diagnostic and some of the various non-inpatient facilities continue to be provided from Lydney Hospital until the new medical centre is provided. And it looks as though this, at the very best, may be several years after the opening of the new hospital. Many residents would find it more convenient to travel to Bristol, Gloucester or even Newport. And I do hope the committee will be able to keep an eye on the small corner of the county. Thank you.
Thank you, John. Thank you very much. Can we now proceed safely to number 5, which is an update on the community phlebotomy services? And I'd like to ask Dr. Andy Seymour to take this item, please, Andy.
Thank you, Chair. Excuse me. Yes, thank you very much, Chair. So, firstly, members will have my report submitted to you, and also you may well have seen some subsequent responses to questions submitted by Councillor Hodkinson as well, which I think is helpful to elucidate and tease out some of the issues. But if I just kind of summarise where we are and remind members of the situation. So back at the end of 2019, December 2019, as a CCG, we were keen to try and standardise and equalise phlebotomy services in terms of community phlebotomy services from primary care around the county, and decided to commission phlebotomy services, GP-initiated phlebotomy services within practices as far as possible. And during the next 6 months, which unfortunately coincided with the start of the pandemic, we spent time with practices to progress and implement local services, such that by the summer, so August 2020, all practices were now providing primary care based phlebotomy services across the county. And that's again, I mentioned this before, but to explain, blood services are based on requests from GPs primarily, but also sometimes from a request from secondary care, so from consultants in advanced outpatients, for instance. Initially, the situation was that a few bloods were also done in the community at the request of secondary care, where capacity allowed in the practices. However, since COVID and the change to a different model of outpatients, where many outpatients are now virtual, the request for blood tests in advance of those outpatients, or as a consequence of those outpatients, to have the blood test then done closer to the patient's home, has increased quite significantly, and that has also put a bit of pressure on the local services. So that's the kind of background for where we were. More specifically, there were some issues in terms of siren tester provision, and over the last 6 to 9 months, we've developed and progressed the service, a service based at Cirencester Hospital, and GHC are now running a phlebotomy clinic there for secondary care-based bloods. And as you'll see in the report, there's some really good progress. It's a service which is running 3 days a week, but as we note, there has potential to go up to 4 or 5 days if required. But current data suggests that there isn't that need for it, because the clinics aren't full. We're utilising it well, but there's still 95% capacity of utilisation rather than full usage. So as we say, if the need is required, we can certainly step up to 4 or 5 days. The other good part about the service there is that it was initially based on fill-in staff, but now GHC have recruited substantial posts, and these people are now experienced in taking blood, and also now looking to be trained to cover the older paediatric aspects as well, so that only children under the age of 5 would have to go centrally for their blood tests. So again, some progress. And you also see some quantitative data from the Cirencester service over the last couple of months, where over 700 patients have had bloods taken there and been very successful. Only a handful of patients have not been able to have a blood done in Cirencester, and that's not through competencies, but due to the fact that the blood itself had to be close to a local laboratory for processing, so that patient then had to go to Gloucester or Cheltenham for that. So a very good service there. And qualitatively, we've had no complaints at CCG, and indeed we've had some compliments as well. And I know the local service has had compliments as well. So progress, I think, compared to where we've previously been, and a combination of factors. Just going forward, as I referenced earlier, that there was definitely an increase requirement for secondary care initiated requests to be done closer to patients' homes. And we recognise this is having an impact on primary care phlebotomy provision. And we are working with the practices, we will be working with the practices the next few months to look to fund the increase in that demand, because we recognise that will be a resource implication. So ultimately, patients will have a choice. Currently, some parts of the county they'll choose and be able to go to their local practice for these secondary care bloods. Sometimes they can choose to go to Gloucester or Cheltenham or to the Cirencester Hospital as well. So a good choice around the county for this, as I say, this is the secondary care bloods. For the primary care bloods, very happy that all practices are offering this service and offering a good service. Just to close, there are always questions about wait times, and I would remind committee that it's quite a difficult thing to make a reasonable judgment on wait times. We've absolutely got assurance from all primary care providers, all practices, that urgent bloods are done within 24 hours, and that's good and appropriate. But when we talk about routine waits for blood, it absolutely depends why the blood is being requested. So, for instance, if a blood test is requested in advance of a annual health check, say in June, it doesn't matter whether you have to wait 3, 4, 5 weeks in February for your blood test to be done in April. So it is a bit misleading to record standard waiting times for routine blood. Nonetheless, most practices are providing routine bloods within a week or two anyway. So but I just wanted to make the point about differentiating between urgent bloods and routine bloods. I think I've covered those things, but happy to take any questions as required.
Thank you, Andrew. Does anybody have any questions of Andrew? Paul?
Thank you. Yeah, thanks very much for taking us through the information, and also for answering my questions. In one of the answers to the questions, you've said that you can report an improvement, and you've mentioned a figure of 700 patients there. But the problem is there are no detailed figures to look at as a comparison of since the change and before the change. So from a scrutiny point of view, I can't see whether it's better, worse, the same. I can't see that. And until I can see that, I don't know how I can scrutinise effectively. So we really need those figures. And in your answer, you've said, going forward, to quote your words, this will happen. But again, when will that be? When will we be able to see those detailed figures, please? We certainly need a comparison between the two. And it's interesting because I've had people contacting me locally in terms of feedback, which doesn't correlate with your own feedback. So something's going awry somewhere. Either people are exaggerating, or this isn't, without the figures, we don't know where the reality lies. As an example, someone said to me, I've just phoned up my Cirencester surgery for a blood test, can't get in for 2 weeks. That was one. Somebody else said, our surgery in Cirencester don't have any appointments for weeks, so I've had to go to Tetbury. So I'm giving you a couple of examples. I don't know whether that's the generality or not, but I guess without those figures, it's so difficult to see. And people locally are still raising this with me, so I'm raising it with you still as a concern.
Thank you. As I tried to explain, it's quite a difficult thing to tease out differences here. So in terms of the first point, the Cirencester Hospital service is for secondary care requested bloods. And I think we've got the quantitative data, and I say the qualitative response is that we've as a system have had no negative comments, and which is certainly a difference from where we acknowledged 6 to 9 months ago. We certainly, as a CCG, we were getting some negative comments. In terms of the second point, which I think you're probably referring to primary care or GP requested bloods based at the Cirencester practices, I'll reiterate the point I made about it's very difficult to define what is reasonable in terms of a waiting time for a blood test. And I'll come back to the point that a waiting time for 2 weeks for a blood test, which has no clinical urgency, I think is not unreasonable. And it's the same in making a GP appointment, for instance, for a routine health check, which is required in several months' time. I think it needs to be balanced on the urgency. But as I said, also in our response, we have had some difficulty getting quantitative data in terms of blood tests because of coding issues, and it's quite a detailed issue, and I'm happy to talk outside committee with you about this. But it's not as straightforward as just bean counting. It depends on codes inputted, and as I said, we plan to try and nail down the coding from April going forward. So going forward, we'll have more accurate data, but it's very difficult to get it retrospectively.
Thank you, Andrew. Paul, again?
Yeah, just quickly, I accept that you're having difficulties with the coding, and as you said, you might be able to fill me in on that later. But the point is, when will this committee be able to see actual data as comparisons between before and after? We really need to have a timescale so we will know when we'll be able to look at that data, please.
Yeah, and as the other slight difficulty, particularly from the Cirencester area, we're moving from a situation with comparing apples and pears, because previously all bloods were done at Cirencester Hospital from both the primary care and secondary care perspective. So because practices weren't providing the service, so it's quite difficult to compare the two. But I say going forward, if we'll start collecting accurate data from April, and certainly within after the first quarter, we'll be able to report back in terms of numbers going through the services.
So the next meeting will have a more accurate record of the comparison.
Sorry, the next meeting will be June. Yeah, if it's June. Yeah.
Thank you very much. Does anyone else have anything to say, Martin, about phlebotomy?
Yep, I did raise my electronic hand. It is just, I had a recent example of an elderly man who needed a blood test in advance of a blood transfusion. So it was a secondary referral. And slightly to my surprise, instead of just what you would think might have been a 10-minute appointment at his GP surgery, he was told to come in on the day of the blood transfusion to CGH, have the blood test, and then had to wait really the best part 4 hours in the hospital for the blood test to be sort of carried out, analysed, and a blood match found before the blood transfusion took place, which actually, especially in a pandemic, and since he was in a vulnerable category, seemed quite unsafe as an idea anyway, but just more generally seemed quite inefficient when that could have been presumably done in 10 minutes at a GP surgery at any point in the previous 7 days, I was told. So I'm not sure if this is connected, but that sounds like an opportunity to improve the speed and efficiency of phlebotomy. But I wondered if it was connected to this, to the difficulty of getting GP appointments for phlebotomy.
So thank you, Martin. Well, I think the point there is that we have commissioned GPs to do a primary GP requested bloods, and as we kind of repeat for secondary care initiated blood, so for instance the blood transfusion, it's where GP practices have capacity. So if a particular practice does not have capacity, enough resources to provide that blood, then the patient will have to go to secondary care to have that blood in advance. So it's something, as I said, we need to look at because of the change in virtual outpatient, which has increased the requests for secondary care blood to be done more outside of the hospital setting. We definitely need to look at the provision. But as I say, resources have to follow, and we are working through that.
Okay, thank you.
Chair, I'm happy to comment on the specifics, Martin. I'm not sure whether you've received the formal response. I've certainly seen that response, so my apologies if it's not reached you yet. But I can confirm that this isn't related to resources or the issue that Andy's alluded to as you questioned. I think your point is very germane, though, about reviewing the pathway for patients such as this one to check that it is the right pathway. There are some explanations as to why the clinician considered this appropriate, but that response is winging its way to you if you haven't got it already.
Okay, thank you. Now we'll have Dilys Neal, followed by Andrew Gravel.
Thank you, Stephen. Yes, thank you, Andrew. You said that to a certain extent, one of the problems was that this new system for GP blood testing had been GP phlebotomy had been introduced during the pandemic when there was a sudden increase in virtual appointments. Are GPs surgeries around the rest of the county, not in Cirencester, where there isn't easy access to a hospital such as where I live in the North Cotswolds? We don't have a phlebotomy service at our local North Cotswold Hospital. So are practices further flung coping with the secondary care requests that are coming from virtual appointments? That's my first question.
Yeah, thank you. Apologies, I probably didn't make the point clear. I was obviously responding in terms of Cirencester issues, but the point about the increase in requests for community-based bloods from secondary care is generic across the county. And absolutely, practices throughout the county have expressed concerns at their ability to manage the increased workload. And that's exactly what I was referring to, that we're looking at resourcing practices to give additional resources so that they can absorb the additional work. So we're looking at funding that and, as I say, resources to follow in terms of physical capacity.
Yeah, and so this is I think this is quite likely to be an ongoing thing, because I'm part of a patient participation group where it seems that virtual appointments are really quite popular. So it seems that in the future we may continue with virtual appointments, maybe not as many as we have now, but certainly it will be something new. So it's likely that this requirement for extra bloods inaugurated by secondary care is likely to continue in the future, I would have thought. Is that your expectation?
Yes, I agree, and I think it probably fits in with our overall direction of travel of services close to the patient at home, and it can only be a good thing.
Be reviewing the phlebotomy service county-wide on that basis, essentially. I think that's what you're saying.
Yes, and that's why we're looking at additional funding at primary care level to match this increase in demand.
Thank you, Dilys. Now we come to Andrew Gravel.
Yeah, thank you, Chair. When Andy was speaking, he referred to compliments that he'd received about the phlebotomy service, and I'm really grateful to have this opportunity to publicly add my thanks to the phlebotomy service. I had to visit Cheltenham for over 2 years, every 3 weeks, and I would say that the service that patients like me received was simply top dollar. It was absolutely the best, and I would hate this debate to be something that made people perhaps less inclined to go to have bloods taken. From my own personal experience, as I say, based over 2 years, it was just in Cheltenham, a great service. It took me a few days to understand what phlebotomy was. It took me a few weeks to be able to pronounce phlebotomy, but the people who took my bloods were beyond expectation. It was a absolutely easy thing to do. I live on the Cheltenham side of Gloucester. The journey was quick, and I appreciate that Paul was talking about issues in Cirencester, but I'm glad to have this opportunity to publicly say, in my experience, over 2 years, not just a one-off, over 2 years, every 3 weeks, it really was a great service. So if you could pass on my thanks to the team, I'd be so grateful. Thank you. Thank you very much.
It's nice to hear, Andrew. Thank you very much. Thank you. Does anyone else want to ask a question or make a comment about phlebotomy? No?
Could we just ask councillors who've raised their hand to lower their hand on the screen, please? Thank you.
Thank you. Thanks very much. Now we come on to item number 6, which is the COVID-19 temporary service changes. And I think we have Ellen Rule, Director of Transformation and Service Redesign, to give us a presentation here.
That's me. Can you hear me okay?
We can hear you very well indeed, but we can't really see you.
No, I haven't got amazing broadband this morning. I think we've had this issue before. It is the for some reason I seem to find the council WebEx system quite difficult to receive. So I will try putting my video on, but if I go really, really crackly, will you let me know, and then I'll go back to just being a kind of ethereal voice in the in the ether.
We'll give you a warning crackle.
How's that? Can you hear me okay as well?
Yes, that's fine.
Still? Okay. Okay. Okay, good. Right, well, I'll start and then we will hear. So we're here today to talk about the temporary changes and the arrangements that we want to put in place to extend those. This is about our ongoing operational response to COVID-19. It isn't about proposals that are in our Fit for the Future programme. I think we have, I can hear somebody else talking in the background, so I don't know if somebody needs to go on mute who isn't, or whether that's just a feedback thing.
Definitely silent.
I definitely hear somebody muttering.
Definitely silent.
And we can't hear it,
okay,
so it must be your
I'll
end.
carry on. You can't hear it. Okay, I'll carry on. Very strange. So basically, going back to the paper, so we're seeking further support for the extension of the operational changes to enable the ongoing delivery of health services in the COVID environment. So this is further short-term changes. It isn't about the term proposals that we for the future programme. So
and then I think you might need to turn your video on.
You may have to go, Ellen, you may have to go to sound only.
Okay, I'm really... I'll go incognito. Yeah, I'll go incognito again. So, okay, so so hopefully you heard me describing that these are a number of temporary changes. We've set up the details in the Memorandum of Understanding pro formas that we use between us to describe service changes, temporary or otherwise. And the proposals that we're setting out today, the first relate to the changes that we first initiated on the 1st of April 2020. So they relate to the temporary reconfiguration of emergency general surgery. And we are proposing a further extension from March to June. We're also then proposing an extension to the set of changes that we first notified on the 9th of June. These include Cheltenham ED becoming a minor injuries unit 7 days a week, 8 till 8. A centralisation of acute medical take, so in other words, acute medical patients who need admission to hospital at Gloucester Royal. The movement of the acute stroke unit to Cheltenham General. Emergency in the elective planned vascular moving to Gloucester. And emergency urology also moving to Gloucester, with planned pathways staying at Cheltenham. So they were enacted on the 9th of June 2020, we renewed in September, and we're now proposing effectively a kind of further final 3 months. We then have a number of community services changes as well. So, the first to note is a 3-month extension of the temporary closure of the Dilk Minor Injuries Unit, Vale and Tewkesbury Minor Injuries Unit, and reduced opening hours at Cirencester, Stroud and Lydney. So these were enacted on the 22nd of March, extended in June, extended in September, subsequently of the temporary closure of Tewkesbury Theatre. We're also proposing a further 3-month extension to the temporary reallocation of 6 general rehabilitation beds at the Vale Hospital to provide additional capacity for stroke rehabilitation to support flow through the hospital stroke units. So again, that was a slightly later change in September, and we are going to extend that forward for a further 3 months. We have now had these in place for a little while, obviously.
Helen has completely vanished.
Incident response. The redeployment of our staff, which is what a lot of these changes have been about, to support core services.
Helen, can you go back about 4 sentences, please? Can you go back about 4 or 5 sentences? Because we had a temporary interruption.
Yeah, sure. Sorry, are you? Hang on a moment. Let me just see if I can improve things by moving again. I'm trying to get as close as I can. And I'll just see if there's anything else I can switch off. I do apologise for this. It does seem to be the web assistant. Charlie, is there anything you can turn off? Thank you. Right. And the perils of having various people homeschooling and so on. Is that better? I've moved to another location even closer. Ah, excellent. I will not move a muscle. I'm so sorry. I'm not quite sure where I was up to. Had I described all the service changes?
Yes, you described those.
Excellent. So I think where I was at then was to say that we proposed to renew for a further 3 months from March to June. This is in recognition of the fact that we are still in incident response in terms of how we're managing flow across our hospital and community sites. So we have ongoing redeployment of staff. But it is also important to note that this also recognises the work involved in the reversal of the temporary service changes and the fact that staff are tired, have been working extremely hard through this period, and that to try to rush through the changes very quickly, what would effectively be this month to the previous timeline, would just represent an unrealistic burden in terms of the work. So there's a number of reasons for this, but we are proposing the 3 months extension. You have the detailed pro formas with the detailed risk assessments with the changes. And I'm happy, I'll probably stop there. I'm sorry it's been a slightly disjointed presentation, but I'm happy to take any questions that obviously that members may have on the paper. Thank you.
Does anyone wish to ask questions of Ellen? No electronic hands up. Martin has his physical hand up. Martin. He's in mute. Are you on mute? Mute.
I think you're on mute, Martin.
I think you're still on mute.
Sorry, I'm struggling to get it off mute. And I did have my electronic hand up as well, actually, but I don't. Maybe they're not being seen.
You did,
anyway.
yes, we can see it, Martin. Yeah.
Yeah. Okay. I just wanted to ask about vascular surgery because I thought, dating back 6 months, we were told that the national advice was that elective surgery should, if possible, be centralised on a green site, on a COVID-free site, and yet. Under the temporary changes, we centralised it in Gloucester. So there doesn't seem to be any analysis of the risk of doing that, and whether there have been any sort of cross infections or anything for vascular patients. But I'm just wondering why that is being maintained at a time when things are coming back under control, and when the ideal is for vascular surgery to be taken to a green site. The other question, just generally, is whether or not another 3 months extension really is absolutely necessary, given the now very dramatic fall in cases and hospitalisation, and the very rapid progress we've made, especially in this county, thanks to many colleagues represented here, and their own colleagues. But it's very good news. But we now have 48% of the population having an initial vaccination, and we presumably don't expect even if there was, some resurgence in case numbers after lockdown starts to lift, we're not expecting those cases to go right back up. So I'm just wondering about the sort of wider rationale for the extension as well. But I just want to ask specifically about whether vascular surgery is on the right site.
I'm happy to respond to that if it's helpful, Chair. So,
okay.
Martin, coming to the second point, unlike the government, who I think's language is no earlier than, this date of the 30th of June is no later than. So if over the course of the next few months we can plan in such a way that we can change services sooner, then we'll do that. To give an example, we've got an implementation of a new information system going into our Cheltenham consultant-led A&E service, and we just need to get the timing of that new information system aligned with the timing of the reopening. So it's a no later than, and if we can do it sooner, then we will do. And we'll also be very mindful, of course, of the appropriate links to some of the national timescales for also reopening up society and releasing some of the restrictions. On the former point, I don't think it's particularly germane to vascular. Across the board, the preference is that major surgery is done in as clean an environment as possible, and you've used the language green, so I'm happy to keep that. However, there are always considerations, and one of the key considerations is about the safety of the service. So whilst a green site may better manage nosocomial risk, so the risk of transmission of the virus within a hospital setting, in achieving that you may import other risks related to safety of complex surgery without the necessary support services and indeed staff around it. So it was those balance of risks for a number of different services, not just vascular, that led us to conclude the model as we did. I'm happy to respond further, but that's it in summary.
Thank you very much, Deborah. Thank you. Andrew Gravels wants to ask a question or make a point.
Deborah's answered my question, and it's reassuring to know that we have that flexibility there. And my question, just a quick follow-up on that, is it is a while since I've attended HOST. Is there a procedure in place for keeping HOST members up to date in between meetings, Chair?
Joe?
I can come in on that one. We have a very good source of communication via CCG and the committee. Any information that the NHS CCG and all the trusts feel that members need to be aware of are sort of immediately communicated to the committee. So it is a good source of communication. Regular briefings, briefing notes, and media are forwarded to committee members.
Thank you, Chair. That's really helpful. Thank you.
Thank you. Dilys Neal.
Chair,
sorry, I was
is it
very
possible to come
glad,
back on the question I asked?
Can we let Councillor Neal finish, then we'll come straight back to you, Martin.
Sorry, Martin. No, it's just a comment. I was very glad to hear Ellen say that we needed to be conscious that our NHS staff were exhausted. I can just imagine that as we start to lift the restrictions and as our hospital services in particular get back to normal, and indeed our primary care services begin to get back to normal, there's going to be an enormous pressure to clear the backlog. And I just think we need to try and, as members of the public, be a little bit patient and allow our poor beleaguered staff to recover. I mean, we're out there applauding them and recognising the work that they're doing. And I know that friends and colleagues of mine have put in extra time and missed holidays and what have you. So while we want our NHS to get back to normal as soon as possible, we need to look at the human factors for our staff as well.
We have to exercise patience, don't we? Martin.
Yeah, thank you, Chair. Sorry, I just wanted to come back on Deborah's reply. Thank you very much for painting the wider picture. That was very helpful indeed. Just coming back on the vascular issue, though, I'm slightly confused. If, as you seem to agree, the ideal is for sort of complex surgery like this to be done on ideally on a green site. And you said that there were other factors relating to the safety of support services and so on involved, and yet vascular surgery used to be at Cheltenham General, so presumably the support networks are there. So it was moved to Gloucester as part of the temporary changes. So surely we should take the opportunity, if it's possible, to move it back. And I assume staffing levels and things must be returning to something closer to normal now. So what is the reason why it's still at Gloucester?
It's a complex picture, Martin, but I'll try my best to explain it. Vascular is not an island, so it relied upon other support services, other staffing groups, rotas that were moved to Gloucestershire Royal as part of the pandemic response. So you may remember that the whole of emergency general surgery moved to Gloucestershire Royal. So the services that had typically supported vascular were not there. We had a particular concern, you may remember, about the emergency pathway, because without a consultant-led ED during the day, we had no means of receipting those patients. Once you bring the emergency pathway to Gloucestershire Royal, it was very hard then to sustain elective care. However, what I would stress is two things. Firstly, if there was a need to operate in the now ageing, but nevertheless, if there's a need to operate in the hybrid lab at Cheltenham in order to secure the best possible outcome, then those patients have been able to be transferred and managed on a one-by-one basis through critical care at the Cheltenham site. But moreover, since the initial pandemic, when we were learning as we went, we've taken huge steps to create safe, green surgical wards on our Gloucestershire Royal site. So whilst we have receiving pathways and red wards and other wards where we know the prevalence of COVID is higher, we've also worked incredibly hard to ensure that we've got wards, and indeed we've talked about our super green wards, for example, where you might have additional ventilation and other measures to make sure that they're as safe as possible. So it's combining all those different factors to give a whole service picture that is safe as it possibly can be. Nosocomial transmission is a really poor outcome for a patient when it happens. We know that it has led to deaths of some patients that were arguably avoidable. So we've taken it incredibly seriously, but there are other safety concerns as well as that one that we've had to take into account.
Thank you, Deborah. Andrew, do you want to say something?
Yes, please. Thank you. Just a quick comment, because I appreciate this is a public record. Martin's comment about 48% of the population having had a vaccination. I'm afraid we're not quite at that level yet. So we're about 225,000 individuals having had a vaccine. So it's about a third of the county. So still very good progress, not quite 48%.
Sorry, I apologise. 48% must have been of something else rather than the total population.
Yeah. The adults, I think.
Yeah, sorry.
Okay, thank you. Do we have any more points to make or questions to ask? No, I think people have still got their hands up in error. So can we proceed now to, if we've got no more people wanting to say anything, we can move now to item number 7, Gloucestershire Clinical Commissioning Group Performance Report by Mary Hutton.
Thank you, Chair. I'll just do a short update. So I think we've already talked about the reduction in COVID infections and the impact of COVID. We are, however, seeing a steady flow of lower level admissions for COVID. So we need to ensure we keep services safe, and we therefore have had to keep a lot of our safety arrangements in place, and that has had an impact on some areas of our performance. And also we are beginning now to plan for our recovery. So you'll see from the report that the cancer performance continues to be very strong in Gloucestershire, and we are a strong performer nationally. And again, colleagues can take comments or questions on that if you have questions. The challenge of flow with the COVID arrangements, as I've mentioned already, is proving a challenge for us in the system, and we're working through at the moment across the whole of the system. And that has an impact on our urgent care performance and indeed our SWOST performance. And we are now working on our models of care, the new models of care we've been working through. So you'll be aware that we were working through the Think NHS 111, and that work has continued. We are rolling out synapses to further groups, to rapid response and to SWOS, so we can have that change in the way we're working. We're looking at our remote working and understanding how we'll build that into our future planning going forward. And therefore, the work is just continuing, and we're constantly monitoring our performance against other areas to understand if there are ways in which we can actually tackle some of these issues more quickly. You'll see that on the IAPT performance and mental health, we're showing really good performance on recovery, and we're working on a mental health plan now for the 21-22 year, which will include both children's mental health and adults' mental health, because we are expecting to see rising demand in mental health in the coming months. So happy to take comments or questions, or my other colleagues will join in on the performance report if there are particular issues people want to raise.
Thank you, Mary. Do we have anyone who wishes to raise their hands? Paul?
Yeah, I'm not really sure where to ask this question, so I'll be guided. It's basically a question about the number of excess deaths in the county over the last year. Is this something I can raise at this point?
Mary?
Yes, I think I'd look to Sarah Scott, who's on the call. She might be able to respond, or between. Yeah. Let's hear the question. We can respond after the meeting if necessary.
Yeah, okay. So I mean, I asked internally in GCC for some statistics on the number of excess deaths over the last year, because I was interested to understand how many extra deaths there had been in the county. I often get challenged as a councillor about why lockdowns are happening, and although we hear all the messages, people want facts. So I got the facts, and actually I was quite surprised because over the last, well, in fact, it was the period from the 6th of March last year to the 5th of February this year, so 11 months, there were 427 more deaths than the 5-year average for the county, 427. But that was out of a total of 6,100 deaths, which means that, I did a little bit of maths, and it's 6% more than normal. Now, I was quite surprised by this because I was expecting it to be many, many percent more. In fact, probably 100% more, if I'm honest, given what we hear and etc. So given those facts, I really need to understand, I think, on behalf of those people who challenged me about lockdowns and all the things that have gone so badly for most of the population over the last year. What is that figure? First of all, is it correct? And secondly, what would be your reaction then to those who say, well, if the excess deaths have been actually not that high compared to normal, what's your reaction to that? And therefore, what would be your response to those people who say, why have we gone through all this?
Chair, can I just comment on this? Because I just feel a very strong emotional reaction to that comment, I'm afraid. We're dealing with a lot of people who have long COVID, as well as people who have people who've died due to COVID. And I'm sorry, but if you don't know anybody with long COVID, then you're very, very fortunate. We're setting up a clinic now to work with those people who've been impacted. And I think we do need actually to get a strong message across that people do need to follow the restrictions and to stay safe in order to manage their own health. And we still have that, as I said, low level of COVID in the system. So I'm not exactly sure the point you're making here, but I do think we're in a very significant position where we need to follow the rules very closely to protect ourselves.
Chair, do you think I might be able to come in there as well? I think someone might not be on mute. I can hear something in the background. I think the thing to remember about our deaths data, I would echo Mary's point. We have lost nearly 1,100 people from our communities from COVID in the last 12 months. 1,100 people. That is a lot. It's a lot of grief. It's a lot of upset. It's 1,100 lost lives. Now, I think there will be a point where you have to die of something, don't you? And I think what the data says is that we've lost 427 more people than we would normally expect to have died in that period. But you know, nearly 1,100 people have died of COVID. And it might be, if we hadn't had a pandemic, they might have died of a stroke or of heart disease or something else, that might have died of flu. We just don't know. But we've lost more people than we would normally do in an average year. I would also say that we've also had many cases of COVID. Some of them are long COVID. Some people have just experienced a really rotten 2 weeks. They felt really lousy. But some people might have lifelong health implications because of COVID. So I think, Paul, I completely accept you're getting lots of difficult questions from members of the public, but lockdowns are set nationally. We do our very best locally as system leaders to try and promote adherence to the guidance, recognising that different parts of our community need to understand the guidance in different ways, and they're motivated in different ways to comply. But I think the statistics speak for themselves, and we haven't brought a dashboard today on COVID, but we can certainly share one after the meeting if you'd like to see the most up-to-date data. Actually, our cases are decreasing, but we have still had a lot of cases in Gloucestershire, and we've lost a lot of people. And I think that is justifying taking some action to try and prevent spread. And it's also worth noting that whilst it's great that we're not seeing as many people with COVID in hospital, we are still seeing people in the community, and we will still see cases of COVID in the community for the foreseeable future. So we do need to learn to live with this, and these what we call non-pharmaceutical interventions, MPIs, as the Chief Medical Officer calls them, the social distancing, the mask wearing, the ventilation will be part of our lives for the foreseeable future.
I think if I can just say something, first of all, I lost my connection, so I only got the first sentence of what Mary said, but she was reacting, I think. What I'm trying to say here is I'm not giving you a personal view about why has lockdown happened. What I'm saying is I get challenged quite a lot, and a lot more recently on this, as people are so fatigued with it. And let's face it, we all are. And we understand the reasons, but we all are very fatigued by it. And so, I needed to understand really what the answer was. And in fact, I've missed it all. So I will have to catch up on YouTube with that. But I think please don't shoot the messenger. I get challenged a lot on this, and I need to have absolute clarity about the information. And when I saw those excess death figures, I was genuinely surprised. I totally get the point about long COVID. I heard that bit before the connection went. But it's those figures about those extra deaths were genuinely surprising to me, because I haven't seen them before. And it is something that we will get challenged on, I think. And that's why I raised it this morning.
Stephen, you're on mute, Chairman.
Paul, I think that the bald mortality stretch figures do hide other statistics which maybe should come to the fore. There may be other deaths from heart failure or things of that nature. But you can't really just take the figures down, or the stretch in mortalities down to COVID. It's a bit of a disguise.
Chair, could I suggest, I'm sorry, I've got to duck out of the meeting for half an hour, but perhaps at the next scrutiny, we could bring a report with a bit more detail in about the data. And we do go through it normally at most meetings. But I think Paul, he's raising a valid question from the people that are coming to him, members of the public. So I'm happy to try and do a bit more of a deeper dive into the deaths data. But we have to remember that 427 is in the context of nearly 1,100 deaths from COVID. So if we put that down as an action for me, Joe, and I'll incorporate that into some sort of report for the scrutiny committee in the NAID Council.
Thank you, Sarah. That would be most appreciated. Thank you.
Noted.
Well done, Sarah. I think you do a grand job saying about shooting the messenger. I didn't like that, but well done, girl. God bless you.
Here. Andrew Gravel's next, please, followed by Nigel Robbins and Martin Horwood.
Sorry, I'm going to step in because
I
need to say this. I made a valid point that people are raising with me as a local councillor and leader of the opposition on the council. I need to have those facts up my sleeve. So when I said shooting the messenger, I'm talking about me here. I gave them a message that I'm hearing. So please don't criticise me for coming here and stating something that I'm getting it. I'm getting in the neck about some of this stuff, where people are saying to me, why do we have to put up with this anymore? So I've got to have those answers. And I think it's perfectly valid for me to do so. I just want to say that on the record. Thank you.
I get the feeling, Paul, that you personally were not being criticised. We were just stating the facts. But if you wish to have a conversation with someone later, we will arrange that.
Whatever.
But please be assured we weren't criticising yourself.
Well, that didn't sound like that, but thank you.
Can we now go? Who was next? Dillis Neal?
I know that I was next, but I'm happy.
I think it was Councillor Gravel, Stephen.
Yeah.
Okay,
I'll wait my turn.
Dillis, can you just stand down a moment, please? Andrew Gravel, sorry about that.
It's okay. I thought Mary put her hand up briefly. Mary Hutton put her hand up briefly in response to Paul. I don't want to speak before you, Mary.
Well, I was just going to say that we're happy to add into the report that Sarah does next time to show the impact of COVID in the county if people feel that needs to be developed. And I understand the point that Paul is making, but it would be a very poor message from this committee that people could relax in any way at this point in the system.
Face, space and hands is still the major message, isn't it? Andrew.
So I just think we all need to choose our words very carefully when we're discussing these kind of emotive issues. What people are saying to me, this isn't the point I wanted to make. And when I go for my daily walks, when I talk to my neighbours and friends, one of the two things people are talking to me about is how smoothly and how swiftly the vaccination rollout is moving ahead. People are actually very, very proud and appreciative of what all you people on this call today are doing. And I think we should recognise that. I just wondered, Chair, if you can advise me if I'm in the right position on the agenda to just say a few words about the fall in new cases per 100,000. Am I on the right part of the agenda? Probably am. I'm not sure.
I think you are far away.
Okay, so last week at a full meeting of Gloucester City Council, the leader of the council, Richard Cook, told all members that he'd written to, it's a shame that he's just left the meeting, Director of Public Health, I've forgotten her name for a second. Sarah Scott, and all of the NHF chief executives and boards and trusts in the county on behalf of the City Council, thanking them for the way in which they dealt with COVID up until now and the fantastic reduction in the number of new cases per 100,000. I don't know, given the geographic spread of Gloucestershire, how many of you are able to see points west every night. But when they started reporting during this third lockdown on new infection rates, Gloucester was alarmingly, the city of Gloucester itself was alarmingly, for 1 or 2 weeks, top of that list. We have more cases than anywhere else in the southwest, in the area that was covered by Points West. Now, when I watched that programme, and I watched it again last night, it's hard to believe that we are now at the very, very bottom of that list. And obviously, that is a great place to be. So I want to place on record my thanks for the fantastic turnaround in the fortunes of our area, of the county, and pay particular tribute to the work that's been done in Gloucester by all of you. And in particular, also, we were talking about earlier at the meeting, there was a question from Brent McInnery about getting the message across. And one thing we know for sure is that in Gloucester, all of you, Public Health, the CCG, all of the NHS trusts, really have got the message across about self-distancing and about what to do in terms of wearing masks and avoiding crowds. So I'm really glad, again, as I was when I was talking about phlebotomy, to have this opportunity to publicly thank all of you for the work that you're doing across Gloucestershire and in particular the city of Gloucester, where the rates of new infections have come down from being at the top, the most acute in the area, where we're now, I'm not being complacent, at the very bottom of it. When we started getting towards the end of that list, I used to think, oh, Grells, you weren't paying attention, you've missed where Gloucester is, and you go lower and lower down, and there we are. That is just absolutely fantastic work. We should all be proud of our NHS colleagues, and we should all be extremely proud of public health here in Gloucestershire, all working together, all pulling together and delivering a great service for the people who we are all, as elected members, proud to represent. Thank you, Chairman.
Thank you. I think there's no doubt about that, Andrew.
Yeah, well said, Andrew. Well said. God bless you.
Can we now go to, I think, is it Nigel next?
Yes, I think so. Thank you. Nice to hear from Andrew. These kinds of plaudits raise questions about the function of a scrutiny committee during a crisis. I mean, because criticism of data, publicly available data, is somehow regarded as being unfair, then it does raise questions as to whether we should be meeting. I know there are much bigger issues and some of the data failures, if you like, or disappointments that we see in front of us. But we must keep analysing this data and pointing out where things are not quite going right, even though we do congratulate Gloucester on their terrific performance. I watch that data every night, and I'm astonished to see the way in which Gloucester has recovered in terms of the new admissions, particularly for COVID. Regularly they're matching the Cotswolds, which has many advantages, of course, in terms of separation and lack of population density. But, you know, we've got to be reasonable about this. We are a functioning scrutiny committee. I want to raise just 2 points. One has already been raised by Martin right at the beginning in respect of the minutes, which is about the ambulance service performance. We do need that data. We used to get it. We haven't had it for a few years. It is quite illuminating comparing us with other areas. Once again, I repeat, the Cotswold always comes out badly. We do expect, of course, ambulance response times to be slower out here than in the urban areas, though with urban congestion, sometimes that isn't possible, but the gap is huge and needs to be reduced. The second point is looking at the performance on page 70 or 74, depending on how you paginate it, the 4-hour performance by site in terms of A&E, there is that great contrast between Cheltenham, which deserves congratulations. Their performance is scintillating. It's stupendous. But is it not perhaps as a result of this is my question, not perhaps for the result of the significant temporary changes in terms of relocating many of the services to Gloucester, where they have really struggled to keep up with those with that particular performance indicator? Are they not connected? I kind of feeling that the previous item on the agenda should have been coupled with this one, performance data, because it's difficult not to draw the conclusions that some of those services that have been transferred to Gloucester have actually made it very difficult for them to keep up with this particular data performance figure. It's like a pendulum. The more you do one, the less you do of the other. So well done, Cheltenham, but I think perhaps your success is a result of taking services and obligations away from Cheltenham Hospital towards Gloucester. That's all I have to say. I think you're muted. There we are.
Deborah, do you want to make comment about that?
I'm happy to respond briefly. Yes, and thank you for the observations, Nigel. If we went back in time, we would see that Cheltenham's A&E performance has always outperformed Gloucestershire Royal, and we've talked here about some of the reasons for that. So the very strong performance we see at Cheltenham is reflective of a trend. However, the reduced performance that we've seen at Gloucestershire Royal is, as you say, as a result of a number of things, including the temporary service changes. And we had to take a view, didn't we? And we took that view together actually as as a committee was whether we were prepared to reduce patient experience for some groups of society because they would wait longer, for example, in order to protect them from the risks associated with having several front doors and inability to control pathways and the transmission of COVID. So we recognise that the response to the pandemic has impacted on patient experience. There's no getting away from that. But what I do wholeheartedly believe is that we've delivered overall safer care. And of course, in managing the pathways that we've done, we have to keep coming back to the whole picture. As Martin said earlier, the context is so vital. It's in changing these pathways and asking people to experience that longer wait in Gloucestershire Royal for urgent care. We've continued to operate on many cancer patients and offer CT and MRI imaging to many patients at Cheltenham General that we simply wouldn't have been able to do had we had both of those departments operating as consultant-led departments as we did before. So it's a complicated picture, but one that I hope you recognise. Overall, in the round, I think the benefits are huge and that we made the right decisions early on.
It's a very trying time. And you really are to be congratulated on the way you're
If I had Professor Hams with me, though, he would remind us all that the light is getting brighter and the tunnel is getting shorter.
Now, who's next? Have we got Martin?
Yep.
Okay, fire away, Martin.
Yes, I was also going to say something on the A&E 4-hour wait and the system performance. And I think since I often highlight when that is deteriorating, even during the sort of light phase of the pandemic last autumn, I think it's fair to highlight this time that on page 8 of the data, there is a clear upturn and recovery in those performance times since January. And I'm sure that reflects enormous hard work by frontline colleagues. So I would just like to pass on this time, for once, congratulations on an improving performance. I do note it is still not quite up to the sort of the performance levels from last September, but the SWOS data suggests there is still, there are still problems going on, which is why I think that looking at the ambulance data in detail is really important, as Nigel said. But I think that uptick in the performance in A&E is really to be praised, and I'm sure it represents staff who are already exhausted and must be working very hard. The other question, though, was the one I flagged up in advance, which was about cancer data, where again it's very good to see that referrals and the speed with which referrals are being dealt with is really back up, more or less up to normal speed, and the number of referrals is also back up. And actually, anecdotal evidence I've unfortunately had within our own family suggests that's right, and that's cases are being dealt with very fast. But I am still worried about this kind of missing cohort. It's still not quite back up to 100%, and at times it was very low during the last year. So logically, you would think, unless cancer has suddenly started, being less incident in the population, there must be some kind of hidden cohort of people who either weren't referred or weren't treated. And the detailed reply I was given just seems to imply those people just do seem to be somewhat missing, but they're not in the hospital system. They're not being held up in the hospital system in any way. So I just wondered, it's almost a kind of public health or an epidemiology question, where we think there is a kind of time bomb ticking of people who haven't had diagnosed cancer or didn't come forward for treatment when they were worried. What's your take on it?
I'm happy to respond to that as the author. I authored the response, Martin, that you're referring to, and I hope what you saw throughout that thread is a complete recognition that we are seeking out proactively and as actively as we can the 11% of patients who in an ordinary year we would have expected to have been diagnosed with cancer. So there's no doubt in my mind that there is undetected cancer within our communities. We can reasonably assume that will be within certain communities more than in others. And again, my full response makes reference to the work that we are already doing, and indeed further work that we're doing to make sure that we target those communities that are most at risk of having not presented during the pandemic because they either for whatever reason, but also in particular because they're already a population that we know are at risk of health inequalities. I had the most phenomenal session yesterday with members of the Black and Asian minority ethnic communities talking about how we can encourage females from the Southeast Asian community in particular to come back into our 2-week gynecology pathway, because we can see from our very granular data that they're a group that are currently not presenting as they do ordinarily. And a great set of videos using 5 Southeast Asian languages that have been put together. So I just share that as a single kind of example of all the work that we're doing. And finally, just on skin, because this is a really high volume pathway and it would be easy to get quite concerned about skin. But again, as the answer notes, is at the time of the pandemic, we also mobilised this version of a virtual platform, telehealth, where referrers can send a photograph of a lesion and we can consult virtually and screen out a large proportion of lesions that are not high risk. So the suppression there, Martin, referrals, I think is, in fact, I've looked at the data, it's not causation, but there's a strong relation between an uptake in advice and guidance and telehealth and a downturn in skin referrals. So overall, and again, what you haven't got here, it's a contextual picture. Overall, partly because of our 2-site, but I think moreover, some of the messaging we did with our public, where we had GPs and lay people talking to this agenda via social media, whatever, means that we have seen less suppression of both referrals and detection than many other communities. There are some hotspots, and I'll just end there. The biggest hotspot for us is lung. So not to alarm, but we can assume that there are around 40 patients with lung cancer who have not been detected this year that we could reasonably have expected to do so. And that's about the way in which we use chest X-ray more generally and have this incidental finding of a lung cancer or tumour that we didn't expect to be there. So that will pick up in due course, but that's a group where we're thinking again about what can our service response look like, where we go out to these communities. We know that lung cancer is a disease of deprivation. Without a doubt, it's associated with smoking and a number of other factors. So that gives us a really clear sense of where do we go. We go to certain communities, certain groups of our population to find those missing cancers, if I can describe it in that way. So I hope that reassures that it's not, forgotten or misunderstood. A huge amount of forward work, as well as just doing some of the kind of more routine backlog recovery work.
Thank you, Deborah. Thank you very much indeed. Now, who have we got now? Let's take Mary Hutton next, followed by Andrew Gavels and Steve Lydon.
Hi, I just wanted to come back on the SWOS data. We have reached out to other areas on SWOS data, and I'm hoping we can get something out to the committee within the next 2 weeks. And then obviously we can talk about it at the next meeting if that's acceptable.
Okay, thank you, Mary. Yes. Andrew?
Thank you, Chair. Be very brief. Just 2 points in a question. So it's good to see Sarah Scott's back on the call. I'm not sure if she heard my remarks about the infection rate dropping in Gloucester, and I don't want to rehearse that, but Sarah, the leader of the City Council, paid tribute to the work that you and all of your teams. I don't want to rehearse my speech, so I won't come out with it all again, but just wanted Sarah to know that City Council leader was paying tribute to you and all of the NHS teams last week at a full meeting of the City Council, and I just repeated that. And I wanted to say in front of you that as far as I could tell, you did all of that work without a single double-decker bus being anywhere in sight. And, that makes it even more special. Sarah will understand the reference to a double-decker bus. I'm not going to give up on them, but I think maybe you proved a point there. Picking up the points that Deborah Lee was making, particularly around lung cancer patients. My goodness me, as somebody who's been through the mill being treated at Gloucester Royal in Bristol a few years ago now, thank God, for lung cancer, my message to anybody would be who thinks they might be in trouble with their health, do not delay, for goodness sake. Go and talk to your GP. The hospitals, all of them are open and working. Do not be afraid, scared. The treatment will be the best. We all know the score. I can understand why people are reluctant, but somebody who's been down that particular journey, I would implore anybody not to even hesitate for a second. My main point I wanted to pick up on, Chair, was around SWOST. And it's been referred to, and performance data response times been brought up several times during the meeting this morning. I just wondered, perhaps Joe can tell me, or somebody can tell me, if the joint scrutiny committee, which I was involved with, and I was chair across the SWOST region, we have Bristol, Baines, South Gloucestershire, everybody on board. It's a really, really useful cross-boundary scrutiny committee. If that still meets, and if so, how regularly, how frequently?
I'm not aware of this meeting. It's a question we can put to SWOT and come back to you, unless Becky can assist there.
Joe, I can answer that for you if you like. It's Andrea.
Sorry, Andrea, come in.
Sorry,
Yeah, sure.
Andrea. As you know,
What?
this was still going when I worked briefly with you on health and then worked with Steve Lydon. The committee actually ceased, it's probably about 4 years ago now. There was a mutual agreement across the region that it had done its job, obviously a lot of the hard work that you'd done initially, and it wasn't deemed necessary to keep it going. So after consulting across the region, it closed down and it reverted back to each of the areas to focus on ambulance responses in their own area, except obviously if there were issues that cross boundaries, so like South Gloucestershire and Bristol, and that they, I think, would be doing joint work to actually look at those issues. So if there wasn't an issue identified, then certain authorities would work together. I mean, Becky may have something else, but that's my recollection.
Thank you.
I was just going to say exactly the same thing as Andrea.
Okay, thank you.
But can I just come back quickly on that? Because a lot of the data that people have been saying, Chair, they'll have to wait until July to receive from SWOST, or whatever the reason for it not being available until July was something that routinely that committee, that cross-boundary committee, and I say it covered all of the SWOST area, would receive. And we were able to compare data from Gloucestershire with other areas too. I understand, obviously I wasn't on that committee 4 years ago, that it may have come up with some good reasons why its work was done. I find that hard to understand how that work could be done, but nevertheless I accept that that was
Andrew,
the feeling.
I think the problem has been the pressures on SWOST in recent months. But I think Mary now has just addressed that we will report that information to you as quickly as possible.
But if I can just finish, Chair, I think somebody maybe at the next meeting of this committee, indeed, depending on who comes back after the May elections, needs to look at that decision and possibly review it with a view to somehow reintroducing it or re-establishing it. If it was down to pressures, personnel and meetings and so on, that could be looked at. But from what I've heard today, the issues seem to be pretty much the same as the issues that we were looking when we, along with Swindon, took the initiative to invite the other members, councils, to join us. And we actually won some awards there on the doorway on the entrance to the County Council chamber whenever we were allowed back in there. It did some good work. It was effective work. And for me, it's frustrating to hear people bringing out the issues that that committee would have discussed and had ready access to. I find that quite frustrating. But thanks for letting me make that point. Thank you.
Thank you. Can I just ask if someone can show by hand whether we need more regular data from SWOS? If you do, stick your hands up, please. That seems to have a general acceptance. So we'll have to arrange to get that information on a very regular basis, because ambulance response times are at the very front end of the health service.
Mary said she could get that information.
Beg your pardon? Who was that?
Mary said she could get that information earlier.
Yes, yes.
Chair?
Yes?
It's Deborah. Can I suggest, in the way that the CCG commissioning report includes performance from a number of providers, that we just talk about how we could regularly incorporate SWAST's performance into that report, and then when issues are flagged, we can deep dive, as we have done from time to time, if that seems necessary, rather than asking SWAST to do something kind of discrete and specific and separate each time. Okay. We cover all other providers in that report. I submitted to Mary, she incorporates it. Would it be helpful if we looked at it on that basis?
That's the word. A lot of nodding of heads going on.
Mary, are you okay with that?
Thumbs up. Mary's on mute.
Yes, yes, we are doing. We're doing an analysis of SWAST, and then we can decide together. The committee can decide which information they would like to have regularly. So let's have the information in the next 2 weeks, and then we can decide to pick that up going forward.
That would be great, Mary. Thank you very much. I think Steve Lydon's been waiting quite a while.
Yeah, thank you, Chair. Can I ask that people go via the chair? Because some people have had 2, if not 3 bites on this topic, while some of us have been playing the game. Couple of points. Yes, going way back to one of the comments about 5 minutes ago, Paul Hodgson, of course, is entitled to ask questions. And of course, it's not about attacking anybody. We have an expression here in Stroud of play the ball, not the man. And I agree with Nigel's comments. There's no point having these committees if people can't ask questions about things. These things are important to people. But moving on, one of the things I wanted to ask about the whole performance data, and many of us have asked questions about the consultation about fit for the future, etc. We need to talk about that because things weren't perfect in terms of performance before COVID. And if you remember, many of us got exercised about a number of stats, particularly about cancer and A&E waiting times. So is it of use to ask that perhaps in 12 months' time, when things may have settled down, how we measure the impacts of fit for the future against these the current performance data or the data that comes up in the future? Because surely that's got to be the acid test for these rearrangements. And my other point would be to Councillor Gravels. Yes, Andrew and I participated in numerous of those meetings across the place. By and large, I think, to say the least, we travelled up and down in various places. I actually saw it. We went back to committee with it. Some of the things they used were, vast majority of them, were people were raising their back step issues. They weren't raising cross-boundary issues. They're raising stuff about their own particular ambulance and their own particular hospital. And to be frank, we came back and recommended to people here that in fact it was a convenient reason for SWAS not to have to come to local committees. That was the key thing I found as chair, that SWAS wanted to use the 2 sub-regional arrangements, i.e. one in the north of the region and one in the south of the region, to do their work via. So we felt it was important at the time. We're talking about 4 years ago, and all arrangements can be revisited. That's the reason we came back and recommended to committee that at the time it served its purpose. But my main point is we are allowed to ask questions. We don't have to always back it up with all the comments about how marvellous things are. Of course, we appreciate all the work's being done, but let's not get defensive, people. People are allowed to ask questions because we ourselves get challenged, and it's important we put it out there. So, but I'd appreciate a comment about fit for the future and what the anticipation and the ambition is to actually correct the performance figures, please. Thank you.
Thank you. Who is next?
Me.
Who said me?
Me. Somebody to answer that. I asked the question about fit for the future.
Chair, I'm happy to come in on Fit for the Future. It's Simon Lansley from the Hospitals Trust. So, Stephen, I agree. And whether we do it through this group or I think you were part of the NHS reference group that we used to value really highly to kind of work up some of these things. I think agreeing, the key metrics that we want to track for Fit for the Future, but also your voice in terms of the phasing of the changes. So remember, Fit for the Future is a 2-3 year implementation timeline because there's estates and workforce and equipment things we need to sort first. So getting the voice of you and colleagues in that phased implementation plan would be good as well. So maybe we resurrect the NHS reference group as a kind of working group to do some of that.
Would appear to be a great idea. Okay, we'll take that forward, please, Joe. Dilys?
So my comment is a sort of feedback to Paul's, which the moment may have slightly passed now, but I was just thinking of his reference to the number of deaths. If we look forward into the One Gloucestershire report, it talks about a memorial garden, which I understand is commemorating members of the workforce, the National Health Service workforce, who've died. Every name a person, the project is called, I think. So when people are getting impatient, we need to remind them that among those excess deaths, there are young people and people who've been working for the NHS who've died. And that's why we're still social distancing and staying indoors, or one of the many reasons. And then also one of the things that I've found horrendous in the last weeks is looking at the enormous peak in hospital admissions. It was up to 40,000 at one stage. Thank God it's come down quite a lot now. So it's not just about the number of deaths, it's about people who've died, the young people, the health workers who've died, and it's also about the huge disruption and stress that it's caused to health service workers, and the backlog of cases and all those things, the people who haven't come forward for their cancer treatments. These are all side effects of COVID, and that's why we need to continue to keep the transmission rate down. And I'm sure absolutely Paul absolutely understands that. I do have sympathy for him, because we all of us are getting that sort of question: when can the lockdown be lifted? And we're all impatient. I haven't seen my 10-week-old grandson, for example. So everybody has has these things. I do sympathise with Paul, but it's a bigger picture than just the number of deaths.
Yes, indeed. Who is next? Mary, do you want to say something?
I just want to mention the Every Name a Person commemorative garden that was in the next report. That is a commemoration of the people who have died through COVID, not staff, thankfully, as we are clear that in neither of our provider trusts have any member of staff died. But we do want to reflect the memory of all of the people who've died during COVID in the county, and other partners will be involved in that.
Okay, thank you. Simon Lansley, have you got something you want to say?
Old hand, Stephen. I'll put it down.
Okay, thank you. And Nigel, your hand is still up. Nigel?
Wait, it shouldn't be up. I apologise.
And Deborah, your hand is there also.
Not at my end. I've taken it down. I'll pop it back on and back off again, Chair.
Okay, thank you. Yes, everything's gone now. We appear to be complete on that report. So, Mary, you're on again.
Yes, thank you. So the next report is the ICS lead report. And in that, we try to give you a set of information to let you know how we're working together across the county on a number of issues. So this time we just cover again the COVID-19 response, because we still have to have our response working. We continuously get new issues coming up, and we're looking forward to the day when we can actually step that down. We have put a little bit in there on vaccination, but the numbers of vaccinations have massively increased since this report, and colleagues can give you some information. And then the report, we've already mentioned the April 21 commemoration of COVID-19. And there was a really good video around the Every Name a Person, where we pledge never to forget that every name a person, every personal life lived, and every life a story behind. We do want to stop in April and just remember that, and there's an opportunity for people to be part of that. So we've then gone on to give you some more information. As we've gone through the COVID period, we've stepped up our work on end of life and palliative care in Gloucestershire, and we're giving you an update of some of the work that's happening. We're due to publish our strategy in April 2021. And we have also been working on the COVID implications around end of life, and we have a plan now to put that out into the community, into PCNs, to beginning to look at their population in more detail, and we're calling that the whiteboard project. We're giving you some more update on living with pain and the living with pain programme. And if you wanted some more information on that could be a topic for a whole event really in Gloucestershire. Across the whole of the system, people have worked together, and also the voluntary and community sector are involved in that programme as well. And a lot given real support to help them to live with pain, which is part of their everyday life, but actually to put that into context of a wider opportunity to be involved in other things and broaden what they're doing in their lives. We've updated on advice and guidance. You can see that as we to do more around the advice and guidance, the digital agenda, and giving you some information on the virtual ward as well, and some information on the mental health online support. And as I've said, we will have a plan on mental health, which we can talk through with you at a future meeting for 21-22. And also then we have just mentioned the future of integrated care systems. That work is ongoing. They're developing legislation and plans, and the expectation is that will take effect from April 2022. And we can again do some more updates on that if people are interested. So quite a lot of information just to tell you the kind of work that's going on, and happy to take any comments or questions, or my colleagues will be able to do that.
Steve, you're on. Steve Castle-Leiden.
Yeah, thank you. Yeah, on COVID, on the vaccinations, this, of course, everybody deserves every congratulation for all the work that's gone on. And I'm pleased that the decision was taken very early on not to have one mass testing centre. And thank you to you, Andy, for your detailed answers, which I understand. I've just seen a note from him we mustn't reveal because of... and I suppose that's the background to my question. I was on a ministerial call, God forbid, where the minister actually said, and the LJ, Local Government Association, have been pushing to have greater reveal of all of the data, particularly on local authority levels, etc., and parts of the cohort. So the minister said, yes, that's all coming out. You should get it. Yeah, it will be done. But as yet, we haven't seen it. And I just wonder if there is any progress on greater reveal of the data, i.e. the breakdowns, etc. And also, where are we in terms of the actual groups that will be done in the future? We've had debates here about police and bin men and God knows what. But I just wonder if there's any feedback at all on that those future stages. But the first one is about the breakdown, because obviously there may still be pockets that we collectively, locally need to tackle to actually try to get them along, to actually take part in the vaccination program and relate to that, to the future. So I'd appreciate an answer on that one if possible, but I won't reveal, Andy, what you've sent. Thank you.
Should I respond? Thank you. First of all, I mean, I can just give you headline figures in terms of vaccination data. So we're up to about 225,000 individuals vaccinated in the county, which, as I said, is tremendous progress. That's about 33,000 done through the hospital hub system, which is primarily health and social care staff, then 190,000 at our PCN sites across the county, plus several community pharmacies as well. So really good progress, and we're now starting on second doses now. Actually, timing is such as that we're catching up with the second doses, so that's all good news. And in terms of the specific cohorts, which I'm sure you know well, we're again making really good progress going down from cohort to cohort, and we're in the very high 90s with the kind of first few cohorts, and in the more recent cohorts now over 90% with most of them. And importantly, we're on track. Vaccine supply being an important point, but vaccine supply being okay, we're on track to get all 9 cohorts vaccinated by mid-April, which is good news. In terms of public domain and data, it is a bit tricky because validating data takes some time to get accurate pictures. Now, I think that's one reason why NHS England are quite careful about releasing data until we're sure it is absolutely clear. And so, for instance, there's a national data collection, and then there's kind of local collection, and sometimes it does take a little while for them to synchronize. So I think that's one reason why there's some nervousness about putting out figures until we're absolutely clear about them. In terms of local variation. We can see some figures at our PCN site, a kind of more place-based site, and it's quite pleasing that there isn't a great deal of variation, which is good. However, where the variation is occurring, it's probably to be expected, and in some of those harder to reach groups, and some of those demographics we've explained earlier with BME groups and so on and so forth. And as has been referenced, we're doing some really focused work on trying to reach those groups. I think Paul's on the call here. Paul is chairing the vaccine equity group, which is making specific plans and projects to reach those groups to raise the number of people vaccinated.
Could I just ask Paul Roberts if he wants to link on to that information that Andrew's given us? Paul?
Yes, can you hear me, Chair?
Yes, we can.
Thanks. Classic timing. My internet connection suddenly seems to do that every time you want to say something, doesn't it? So just to say, Sarah Scott as DPH and Mary as system leader asked me to set up a vaccine equity group, and its specific responsibility is to try and make sure that there is equitable take-up of the vaccination. And we know there are some inherent issues with that because evidence research suggests that there are going to be certain population groups or community groups that are hesitant in taking up the vaccine, and others where our conventional vaccination arrangements might not be particularly accessible or convenient for those groups. So I have a group that spreads across the third sector, local government and the NHS, and we're doing a great deal of work on trying to make sure that we get vaccine equity. I think that we're looking at the data, and there is better data coming out now because ethnicity, particularly looking at vaccine take-up, is now being recorded, and we're beginning to get some quite good data on that. The reassuring thing is at the moment there is very little evidence of lack of equity in the early cohorts, i.e. the older age groups and those who are clinically vulnerable. We anticipate there being bigger issues as we get into some of the younger age groups, and therefore we're doing a lot of doing a lot of work on communication, and we've translated all of our information. We're working with trusted community leaders. We're organising pop-up vaccination clinics to go into trusted venues for people that might not want to come to some of our NHS venues. Last week we did a particular push on vaccinating homeless people. We've got some further work to do on that, but we made some really good progress on it. And therefore our anticipation is that we will do our very, very best to make sure the vaccine is equitably taken up. But as we know, the evidence suggests that's going to have to involve a real concerted effort, because the evidence is telling us that there are going to be reluctance from certain communities. So lots of people involved in that work, and I'm coordinating it on behalf of our system.
Thank you. Thanks very much, Paul. Can we then ask Colette Finnegan if she wants to say something?
Thank you, Chair. Yes, Chair, this is for Mary. Yeah, Mary, when we talk about a memorial garden for COVID, I think we have to be very careful. During the time of COVID, cardiac deaths have been up by 40%. And cancer deaths, cancer data, I don't know. How much of this is down to cancelled appointments at our hospitals or missed appointments due to COVID? Again, I'm unsure because we don't have that data. So out there, personally, 3 people in my own family have died in the past year. Again, missed appointments, etc. So the memorial garden just for COVID, I think it would be the wrong thing because there's lots of people who lost family members, not just because of COVID. Thank you.
Thank you. We'll now
Sorry,
take...
can I just come in there? Because it's really important to be accurate here. So this garden is a garden that we're developing at Gloucestershire Royal Hospital. I think that's the one that we're talking about, and it's a commemoration of not just those that lost their lives during the pandemic from COVID, but anybody who lost a loved one. But moreover, it's also to enable people to commemorate and reflect on the contributions of key workers, NHS staff, etc. So it's a very broad piece. It's not a memorial garden for COVID deaths. It's a much wider, much more reflective piece than that, and will be a place that patients, visitors, staff can go and sit to reflect on whatever it is that they want to reflect on that's happened in the last 12, 18 months. Hope that helps.
Come back, Chair. May I come back?
Yes.
Yeah. Thank you very much for saying that, Deborah, because that's much clearer. And for the public looking in, that's a much clearer description than what was already said. Thank you.
You're welcome.
We'll have Paul Hodgkinson followed by Martin Forward.
Yeah, thank you, and thank you for the wonderful vaccination figures. It's just amazing, and I can't wait to get mine whenever that comes in the next few weeks, hopefully. I wanted to ask about who should be contacting their GP surgery if they haven't had a vaccine yet. So I remember a few weeks ago the government said that all over 70s who hadn't had the vaccine call should get in touch. Is that now coming down to over 65? If they haven't had the call, should they be contacting their GP surgery, or is it and also the 16 to 64-year-olds with underlying health conditions? That would be just helpful to understand that, please.
Thank you. Yes, the situation is a little bit more complicated than it was with the previous group, because GP services, i.e. through the PCN sites, are concentrating mainly, but not exclusively, on cohort 6. So cohort 6 is the one with patients with chronic disease, or those under 65-year-olds with chronic illness. And it's quite a big group, and not always an easy group to capture because of, again, getting precise data. At the same time, they're also doing the cohort 5, which is the 65 to 70-year-olds. Those groups and the age-related groups are being contacted nationally and invited to go to national booking centres, which might be Bristol and Bath, or to go locally to their community pharmacy as well. So I think we're not at the situation yet of asking those people to be contacted yet, because there are two to contact GP services, because there are two ways of accessing this information. As I said, through the national booking centre, which hopefully is happening now in the next few weeks, and I understand letters are coming out to the 60 to 63-year-olds very shortly. But in a few weeks' time, certainly there will be this kind of, I suppose, inverted commas, mop-up exercise just to make sure we haven't missed anyone. So I don't think we'd be asking people to contact GP services just yet.
Martin Forward.
Thanks, Chair. First of all, on vaccination, I'd just like to say thanks for the jab. I'm in cohort 6, and it was very painless, very well organised, very impressive operation. And I hope many more people get it. But it's a very impressive operation, as everybody has said, and thanks to all the frontline staff for delivering that. I just want to ask about the rollout amongst the wider population. We know that Black and minority ethnic communities, quite apart from the sense that there is some higher level of reluctance amongst those communities to get the jab, we also know that outcomes, certainly in the earlier stages of the pandemic, were significantly poorer amongst that population. So is there a double argument for actually prioritising Black and minority ethnic members of the wider cohorts as we progress, so that first of all that issue of worse outcomes is tackled first, but also so that there are lots more good examples of people successfully having the jab without any ill effects? I think I might, my second question is about second set of questions about fit for the future, so maybe I should just allow a reply to that one first.
Okay. Well, shall I respond? I mean, my response, Martin, is probably a generic one, but essentially we are following JCVI guidelines, so therefore we're taking people through the cohorts in terms of an age-based apart from the chronic illness and clinically extremely vulnerable. So I think we have to follow those guidelines, and clearly as Paula outlined, we will target particular groups, but as they fall within the particular age range cohorts. Although I do accept the point you're making.
Well, except that you'd still be following the guidelines because you'd still be doing the same number of people in that cohort at the same time. But it's a very, very big cohort. As you get down the age ranges, these are getting enormously bigger, these cohorts. So you could prioritise within the cohort, still meet the deadlines, and perhaps tackle this issue about Black and minority ethnic populations.
I can see Paul's got his hand up to respond.
Paul Roberts.
Yeah, thank you for the question, Martin. Yeah, I mean, I think as we get into those younger age groups, we will be doing some very targeted work with some of those communities. So as Andy says, we can't move outside the order, which is that which the JCVI give us. But within those cohorts, we will be anticipating some hesitancy, and also in some cases, because we're looking at cohorts also like asylum seekers and migrants and travelling communities, and as quite a wide group of people, we will be anticipating some of both the access issues and the hesitancy, and having targeted approaches. So in a sense, I think that's probably doing what you're suggesting. So it's not taking out of order. It's just using targeted approaches to make sure we get equity as we go through those groups, or try our best to.
Sorry, just to be clear, I never suggested changing the order of the cohorts. I was talking about prioritisation within the cohort because of worse outcomes.
And so, Martin, if I can just respond to the point, because it's really clear the point you're making. So twofold. Having looked at this, we know that the ethnicity status of patients on the national spine, the database that generates the call and recall, is very low. So practically, it's not easy to identify those groups. But also, when we're at full tilt, which we will be in 2 to 3 weeks' time, when the vaccine supply issues smooth out, we'll be doing around 50,000 a week in the county, and there isn't more than around 100,000 in each age cohort, actually. So we're talking about a week or two. So I think those two factors combined with what Paul said about targeting messaging means that we're probably doing as much as is reasonable. But the final point I'd want to also note, noting that we're always on record at these meetings, is that really positively, mortality and morbidity outcomes for people from Black, Asian and minority ethnic communities in Gloucestershire is considerably better than the national norms, and indeed outcomes for BAME communities were better than those for white communities in Gloucestershire. So it just feels important to note that.
Thank you, Deborah. Thank you.
Shall I ask my second
Yes,
question?
please, Martin.
Thank you, Chair. Right, this is about Fit for the Future because it doesn't appear anywhere else on the agenda. And I would just like to raise a general issue, actually, that I'm very surprised that since we were told back in January that there was a decision point coming in March and that implementation would follow from April, that we have not got a major agenda item on this committee's agenda, or that no paper has been presented by the health community, actually putting forward the final business case, putting forward perhaps some version of the papers that are going to be going to the board. And instead, we are told that, we've got a sort of one-page summary of a bit of consultation outcome in this report. And yet there is going to be a board decision on one of the biggest reconfigurations of Gloucestershire Health Services for years, taking place in a matter of weeks, and that presumably implementation will follow, as we were originally told in April, and our next meeting is in June. So if we want to challenge this, if we want to call it in, or if we want to ask some serious questions, we will practically have no opportunity for doing so until 3 months after it has started being implemented. And I just don't think that's acceptable, I'm afraid. And I think perhaps, Chair, we ought to look at an emergency meeting towards the end of this month, or perhaps early in April, to look at some of this, because I'm still getting material that calls into question some of the decisions. I mean, colleagues know that I've questioned whether or not this is right to go ahead anyway when we still haven't learned the lessons of the pandemic, and our earlier discussion about vascular surgery and whether it's sensible to centralise that all on the same site as the acute emergency and sort of higher level emergency site, because that, in the case of a pandemic, makes it impossible or very difficult to then relocate something like vascular surgery onto a green site. I've raised the issues of leading questions before. We had a consultation, I'm afraid, that asked people questions like, do you support a centre of excellence, which, surprise, surprise, and most people thought you should, and didn't ask them, for instance, should you close the 24 acute medical beds at Cheltenham, which I think would have got a very different response had it been asked. And we have questions that have come to light. I've just got some material from the South West Clinical Senate submission to this process from last August, which raised really serious questions about whether these proposals meet the so-called bed test and whether Gloucestershire Royal will have the capacity in beds to cope with this centralisation. And if I quote briefly from that report, sorry, I've now lost the relevant document, but let me see if I can find it quickly. The panel were told that there was no net change in bed numbers across GRH and CGH, and on this basis were provisionally of the opinion that the bed test was met. However, details of bed numbers in the PCBC, the business case that is, were felt to be unclear and impenetrable. And since then, there has been no discussion of whether or not the Clinical Senate's view of the bed test has been met. There is evidence in the business case that there are expected shortfalls in bed numbers for at least 2 or 3 years under this proposal. So there are real questions about whether or not Gloucester Royal really does have the bed capacity for some years to cope with these changes. And we have another issue that the Clinical Senate raised. There is concern, and I'm quoting here, that maintaining a full emergency department at CGH is not sustainable without other codependent clinical services. In other words, that the so-called restoration of A&E at Cheltenham is not really compatible with these changes, and that actually this might be sounding the death knell for A&E at Cheltenham in the long term. So these are really serious questions. Other colleagues haven't had the chance to look at this Clinical Senate report, and we haven't been presented with it. And we haven't even been presented with the business case document, which is going forward. And I've even heard just in the last 24 hours that there may be a different configuration of general surgery being discussed, which wasn't part of the, whatever it was, year plus system of options appraisal. And that's, that may be being considered. So, these are huge issues. This committee should be discussing them, and we should be discussing them at a point when we can actually influence events. Because otherwise, I fail to see the point of this committee. Thank you, Chair.
I tend to agree with you, Martin, that this committee should discuss the items that are fit for the future. Can that get anyone else's opinion, please? Mary?
Shall I? I'm happy to start, Chair. Sorry, I was trying to put my hand up, but I can't seem to do it. So sorry, general IT incompetence is the theme of today. Martin made a huge amount of quite extensive points. I've made a few notes here, so I will attempt to cover his points, and I'm sure he'll let me know if I've missed any of them out.
Thank you, Ellen.
So I think in terms of the sort of programme, the order we take things, and so there was a sort of generic point, I think, in there about what should or should not have been presented to the committee in March and so on, versus what we presented in January and what we've presented previously. So we obviously brought the proposals earlier in the process, earlier in the consultation, at the start of consultation. We brought the outcome of consultation report in January. We have been in communication since January asking if there were further questions or queries that any committee member wanted to raise of us or any concerns. We have not received any questions or comments despite soliciting those on a couple of occasions since January. And obviously, we do have an ongoing dialogue, as Joe has referred to, about what you wish to see. We are happy to bring more material if you would like to do it. And I'm obviously happy to arrange a session this month with members to talk about anything in more detail if you don't feel briefed on the detail. And I'm obviously disappointed to hear you say that you feel you haven't had things that you want to have, because we are very happy to bring them at any time. So very happy to get something in March as soon as you want to do that. And if there are questions outstanding from the material we presented through the process, particularly from the January meeting, because we did acknowledge, didn't we, in the formal session, that people hadn't had the report for very many days, and therefore we expected submission of questions, which we were happy to answer in the meantime. Then we would pick those up. So if there are still outstanding questions, we are very happy, remain very happy to answer them, whatever they are. With regards to then your quite wide-ranging trot through a number of other very significant issues. So I've made a few notes. So you particularly talked about beds test and the bed numbers, the codependency of A&E, the Senate report, where that was made available, and its relationship to the business case. So I'll try and take those things, and then if there's anything else, then let me know. So the Clinical Senate is part of the assurance process that we work through with our regulators, NHS England and NHS Improvement. It's part of the materials that we have made available in public since September, from memory. It has been available on our website along with the pre-consultation business case. It was printed and mailed to a considerable number of consultees who asked us for that material. It remains available in public, and a précis of some of the elements of that information have been included in documents brought here, as well as in the consultation. So it has informed our response all the way through. At the point of the summer, when we were going through the assurance process and the conversation with the Clinical Senate, and at the point of drafting the pre-consultation business case, that is, by its very nature, a pre-consultation business case. So the point of the stage of the process is that you are pre-consulting on your preferred options. So you do not have your final options. So there is a very difficult balance for us as health services to strike with regards to the amount of detailed resources we commit to pre-consultation options. So we obviously have to work them up to a degree to fulfill our mutual understanding, both for ourselves and our regulators, that it is possible we could deliver them. So, for example, you know, the question we've had before and we've discussed at this committee, could we build a brand new hospital and put everything in it? We've tested that we don't have the money to do that. And so we wouldn't put that in as an option. So you have to test them to a degree where you know they are deliverable. They are not, though, your final worked up proposals, because then we would fall into another difficulty, which would be the predetermination of options prior to consultation. So when they talked about, in principle, the bed test is met, that is because we had an in principle bed model, and we have an in principle test case, if you like, the PCBC, the pre-consultation business case, that is saying, broadly, can we deliver these proposals? Now, the other point of a business case is to test your implementation plan and to highlight for us as health services where we may need to invest, or the challenges. The whole point of stress testing this and modelling it is so that we know we can implement safely. So Simon has already referenced that there is a concurrent estates investment programme. So they're not within the same programme, but there is a concurrent estates investment programme to ensure that we would have the appropriate capacity to deliver over the next 2 to 3 years. And that's another reason why Fit for the Future doesn't implement on, you know, if agreed, it wouldn't implement on the 1st of April because we don't have all the capacity in place to the standard that we would wish to have it to in order to do that. And that's why it's an implementation programme over several years. And we would be more than happy, always open to sharing all of this detail, to take you through that bed model, to share with you the absolute detail on every element of that through the general acute beds, the DCC beds and so on. So I should not use acronyms, the critical care beds and so on, and how that aligns to our estates plan. So we absolutely know how all of that is delivered. That wouldn't be at pre-consultation in a business case. And that's why the Senate's agreement is in principle. So that detail is all there. We're very happy to share it. They did also raise those questions about A&E. You're absolutely right. That is in that report in public. And that also tells us, because we have that firm commitment to A&E, that we need to ensure we have the right codependencies in place. So they're flagging up to us as an independent body to say, this is something, if you wish to maintain that commitment, which we do because we have made it, then we need to ensure that we have the right codependencies in place. If that's what that is saying. It isn't a kind of a saying that, we're not at the whim of that, if you like, because we have to ensure that the right configurations are in place. So all of this is about ensuring we plan to deliver the service model that we wish to deliver, which includes a commitment to Cheltenham A&E department. So that's what that statement is saying. I don't know if any of my GHT colleagues wish to comment, but that, I think, covers the points you raised, but I don't know if other people do want to come in on that response. Did I miss anything else of my list?
I think the most important things, I think the point that Martin was probably trying to make was really a point about process. So, Ellen, you haven't tried to do this agenda item when it wasn't agended. I think, respectfully, Chair, it's for the host to decide how it wants to exercise its scrutiny responsibilities in relation to these changes, which we've understood from various discussions pertains to your right to examine whether the process was adequate and discharged effectively. If you consider it wasn't, and of course, as Martin described, others will know, you have the right of referral through a number of different routes. So, as Ellen said, it never been appropriate to bring the proposals here ahead of boards exercising accountability to make decisions. But the HOSC, in my view, would serve itself well if it met very quickly after those boards to consider the points that Martin's raised. And I, for one, and I now speak for the colleagues, would be happy to come along and support that meeting in whatever guise you decide it should take, because I'm particularly keen, as Ellen has demonstrated, to make sure that when you make that decision, it's informed by all of the facts, because there's a lot of moving pieces, there's a lot of misinformation circulating, and there's information that clearly some members have access to that others don't. So that would be my plea, is that we rein this back into process, and we may need to do that outside the meeting.
Yes.
Yeah, and quickly, as you said.
And quickly.
Yeah.
Steve Biden, do you want a word?
Well, yes. I mean, Deborah's helped. I mean, I suppose I agree with Martin. I put it in the comments. You know, we need to question or get the legal definition of exactly what our role is, because throughout this process, I think many of us have been confused. Are we a consultee? Are we an active partner? Do we have any actual final say? And I think it does get very confusing, because, you know, we know you've got the NHS has many audiences, and ultimately, I think, ends up with a minister. And of course, there are changes coming about structure. Something as important as this, it may just be a diary and a scheduling thing, but I do think we need to catch up, because otherwise, what is our role? You know, the major changes being proposed, surely it's not just for me, it's not just the individual bits, it's the whole package. And then what are the monitoring arrangements in the future, etc., and what are the funding arrangements to put in place for that? So I think the principle itself needs to come back here. And the paper was presented to HOS, which set out its role. Yeah, I've seen all that, yeah. But I expected, though, and I think perhaps stupidly, that we would actually come back with a whole deal, to at least come here to actually have a run through what the consequences are. And we appear to miss that, but then again, I shouldn't be surprised, really. because I do actually think our role does get confused in all this. So I'll be with you, Deborah. I think we need to have a special meeting to actually go through it.
And I do agree with you, Steve. We do need a special meeting. This is a really important subject, and it's an important subject for the years ahead.
Could I just remind everybody, we will be going into PERDA from the 26th of March. So any meeting that is, or session, would need to be, technically to publish papers would be before the 19th of March, if you want to do that prior to the election.
We could go on the 17th of March.
We've got to publish papers a week before, but yes, the 17th of March is fine, yeah. The PERDA starts on the 26th of March.
PERDA starts on the 26th.
When does the board meet? On the 17th of March.
Pardon, Martin?
I was just asking when the board meets.
11th of March. 11th.
11th of March.
What I said, Stephen, is that the County Council meeting is the 17th of March, so it couldn't be that day.
Thank you, Paul. Patrick's Day as well. Could we go the week before that? Could we put something together for the week before that? Which is next week, of course.
What about 16th or 18th?
I think you'd have to be flexible on the paper dates, because here the paper dates can be available till after the board meeting.
Yep.
I think this might have to be looked at outside the meeting if we look at potential dates before the 26th of March, basically. Would you like me to try and circulate, work with Mary and Deborah and Becky to look at possible dates and then come back to the committee to see if those dates fit in with your other commitments? Could we clarify from members what your expectation is at this session and what your requirements are? Perhaps Martin, do you want to come back on that one?
I would expect a presentation of the full business case and a review of the decision that the board has taken, with as much supporting material as the health community wants to present us with. The more the merrier, in my view.
Well, that's short, sharp, and to the point, isn't it? And I tend to agree with you.
And thank you, Chair, for your support for a special meeting. I think that's very welcome indeed.
I think we'll have to have a pre-meet before then to get things lined up.
If I take offline as an action, and I'll consult with the committee and consult with the NHS and try and put some suggestions forward on how you wish to review this and scrutinise. Would that be acceptable to the committee?
The 18th of March. Can we pitch for the 18th of March?
I think we'll have to take it offline, Stephen, because we don't know what commitments everybody has.
Fine. We'll all be head over heels with Guinness after St Patrick's Day.
18th of March is planning, and also for City Council meeting that day. That's if planning goes it.
I think there's a lot of people involved. I think we need to. We'll have to look at some suggestions and send them out to everybody after the meeting, if that's acceptable.
We'll promise to do that, and we must get it sorted quite quickly. Okay, thank you. After all that, where did we get to? Are we on number 9 now?
Sorry, Stephen, can I just come in, because I think it's a really just important point. Is I think it would be helpful ahead of that meeting for health partners to see the terms of reference, because I'm still concerned there's some confusion in some members' minds about the mandate and remit of the HOS. So I think just to avoid an aborted meeting or a meeting that doesn't get members where they want to be, if we could perhaps work with you on that, back to Ellen's paper, because we both took legal advice from our representatives and ended up with a position we were all comfortable with. So might just save us some time, not going around that loop again.
Yes, it will indeed, yeah, we'll do that. Okay, now can we come to number 9 now, please? Have we got that? The clinical chairs and accountable officers report. Mary and Andy.
So I think this sets out quite a lot of information then on the various aspects of health, including all of our health partners. So I would just be happy to take questions. In there, we include a bit of good news, which is that we've been working quite hard with the voluntary sector, and there's quite a lot of work that is across the whole of the system, including the police. Might be something Huss might be interested at a future meeting, and we've been awarded 550,000 over the next couple of years to work on this, particularly with a focus around improving health and care for those with the worst outcomes. And there's quite a lot of other initiatives happening in that space as well across the whole system. So I think if people just have questions or comments or thoughts from that report, we'd be happy to take them across the system.
Okay, we've got Steve Loudon and Martin Howard already sharing. So Steve?
Yeah, it's only a quick one. It might be you can do that offline, but there is a problem about where to raise some of these issues on an agenda like this. But I know that a colleague of mine sits on the Berkeley Vale group, and she's contacted me about the whole issue of GP practices and who and how is actually going to look at running them in the future. And I just wondered if you could do us a note perhaps later about, I understand there's a US health insurer called Centene that just bought one of the biggest UK GP practices. Over 500,000 patients are now going to be passed over to this American health company. And I know there were discussions which I had with Becky about trying to ensure that practice in, I think it was Frampton, stayed local. So I just wonder if you have got guidelines to try and ensure that we don't allow our GP practices to be subject to such takeovers by an American agency which won't have any interest of our local patient care. But that's a comment. But I just wonder if somebody could actually do us a note about what the view of our CCG is in this.
Yes, well, we can set that out, and we can set out the process as well, and showing you how that decision would be made for this county. I think it's a very, very, very low risk for Gloucestershire. Andy, do you want to comment?
Yeah, I was just going to comment. It's precisely as you say. It's all our practices are stable at the moment, so I don't think there are any issues at the moment. But it'd be worthwhile our team just setting out processes if, unfortunately, we end up in that situation.
Okay, thank you. And now we've got Martin Howard.
Thanks very much, Chair. Both of mine, they're almost more comments actually than questions, but they relate to GHC in particular, and two things that aren't very specifically mentioned, but this is the closest we come to them on the agenda, I think. One was the question I submitted in advance about the Trailblazer programme on mental health in schools. And just to say, I think it is important that we do come back to a full report on this at some stage at a future meeting, because actually the detailed reply I got suggested that had developed in a way that was very much focused on interventions for people who felt they were at risk. And it's very positive in that respect. But actually what we discussed at the very early workshops on Trailblazer at the CCG, and this is going back quite a few years now, was actually something that included a much more holistic approach that looked at the determinants of mental health in schools and how the school environment and the home and social media and school environments interact. And I think that kind of holistic approach was something that was very promising and very important. And it may be because of the way the pandemic has, interrupted things, but the Trailblazer programme doesn't seem to be, according to the reply I got, going down that path. So I think it would be great to bring back the issue of children, school children in particular, and mental health to a future meeting. The second one was, again, on GHC, and this is a purely anecdotal example, I'm afraid, but it's a very positive one. We've just had recent family experience of GHC's new complex care at home team, who support people with complex needs who are living in the community. And I have to say the experience was transformational. It was really, really positive. It was somebody, a community matron in this case, who could finally join up all the different services and all the different disciplines and make the right phone calls and had the knowledge and expertise and status to do that. And it was extremely positive. And I just wanted to feed that back to GHC and congratulate the complex care at home team. I think they deserve real praise. And obviously at the moment, under very difficult circumstances.
Thank you. That is very good to hear.
Thank you, Martin. That's good feedback. And if you've got time to write a note, it's great to pass that feedback on to the individual members of the team. If you've got time, I know you're busy, but that would be great. Thank you.
And I think Mary Hutton is offering a separate meeting to talk about trailblazers. Is that correct, Mary?
Well, it is quite difficult to get everything across in a very short briefing. We'd be very happy to have that meeting. If a couple of people just wanted to have that discussion, so we could just test that. I do think that holistic approach is there, very much front and central of the Trailblazer. And perhaps when we write the report, we just emphasize certain elements. And so we'd be very happy to have a session where we just sit down and talk it through with a number of people, and just to test, and then to agree which elements to write into a report or a presentation, if that's helpful.
I think that would be helpful. Do you, everybody? Deathly silence.
It would be good to have it back to the committee, though, for a full discussion.
Yes, yeah.
I'm suggesting maybe a pre-meeting, Martin, with a couple of people first, just to understand exactly which elements, if that's helpful, that we would emphasise.
Yeah, as well, would be okay.
And that will go on a future agenda.
I think that Sarah might have wanted to come in. Did you want to come in, Sarah, Scott?
I was just going to say that, and Andrew will correct me if I'm wrong, but I know that my team participated in a scrutiny workshop for members of the Children's Scrutiny Committee around children and young people's mental health. And it might be that the content of that Scrutiny Committee workshop would be helpful for this Scrutiny Committee. So it did look, I think, at the broader issues around children and young people's mental health services, including the Trailblazer, and could one have picked up some of the issues that Martin's raising. I just wondered whether it might help, because that was already been prepared, and it was relatively recently, I think, Andrea.
It was November.
Yes, it was a joint workshop for adult social care, children's and health scrutiny members. There was really good attendance. It was jam-packed with information. I do have some of the presentations which I can share, and also going into the new council in terms of member development. One of the things that myself and Joe would be looking at is to actually organise another of those meetings to actually catch up with where we are now, particularly post-COVID, and what we've learned. So that is in the member development plan, maybe not written down somewhere yet, but it's definitely on my plan to actually organise another one of those as well.
That would be good to run with that, Andrea.
The event was on the 26th of November, I think, but bearing in mind we are going to be on our next item looking at reviewing the work of the committee and going forward, making suggestions for the new committee. We've also got an induction meeting in June, followed very quickly by committee meeting in July. So really, then I think the next item is where you as a committee start to scope what you feel that the new committee might find useful going forward, which can include the items that you're referring to.
Okay, thank you, Joe. Have we got any more questions or comments to make, members? No? No. So we then come on to number 10. Joe, do you want to take this one forward? A work plan review, 2017 to 21.
Yep. Members, to help with the process, I circulated something yesterday, which was just the key items that the committee have considered from meetings from 2017 as the former committee arrangement and the new committee arrangement. If members prefer to email their suggestions after the meeting, that's absolutely fine. If they wish to suggest any items that they feel should be on the committee work plan or suggestions for the new committee going forward, I'm very pleased to take them here. I have noted a few going forward. We've got the ambulance service, SWAST. We've got the Trailblazer. We've got reviewing IC systems as a topic going forward. But this is an opportunity, if you're looking at that review list, if there's anything you wish to raise. I know that Councillor Pam Tracy has mentioned revisiting a review of the work of pharmacies, but now is the opportunity. But also after the meeting, I can circulate the list again, and you can put your suggestions forward through the chair. Thank you.
Okay. Do you wish to do that after the meeting and send messages to Joe about what you wish to appear on future agendas?
Chair, may I come in, Pam Tracy?
You may, Pam, then Paul.
Yeah, it was a big concern going back with the pharmacists. There's been a lot of upsets regarding the pharmacists. I'm not saying they're not doing the job. I don't know where to go backwards. A lot of people now don't seem to be getting the full pack of tablets, and they either got to go back or if they have a delivery. And sometimes one might forget, and when they phone up for their next month's supply, and they realise they haven't had them. Also, there's a lot of people now with the doctors. There was a certain man waiting in the queue. He went to the farm, and he went to the doctors, and they said that he had to go home and email to get his prescription. Well, a dear lady went home with him, so she had to email the pharmacy for his prescription. And this is quite common. Some surgeries will not let them, or they can't order their tablets, and they've got to email them into the pharmacist. So I think there is a lot of it misses with these pharmacies. And of course, in these times, it's could care less attitude as such. I'm not saying, I've experienced it as well. And I think, where's those tablets gone? And I realise then, well, they haven't sent me the rest, or I've gone to get them, or it's probably lost on a shelf. So people sometimes not getting their full prescriptions. And my other concern is a lot of people who are not computer minded, and I wouldn't be too, to be told you've got to go home and email back in what prescriptions you want. I think that's
so that subject does merit a place in our future work plan, doesn't it?
Yeah.
Yes. Paul.
Yeah, thank you. There's a couple of things that I just wanted to raise. Obviously, I'm happy to email Joe separately. One is that I think we should look at mental health and particularly the impact of the pandemic on mental health for people, both adults and children, because I think it's been quite extensive, but I'd like to understand more about that, really. And secondly, sexual health, but I'm not sure whether that fits with the other committee, because it falls under public health, really. In terms of, again, the impact of the pandemic, anecdotally, I'm hearing that people are not going to some of our clinics. They're not getting tested so much because of the pandemic, worries about that, etc. But I want to understand more, because obviously this is anecdotal rather than the actual figures suggesting that. But maybe Sarah can sort of comment.
Yeah, Sarah, could you provide information for us?
Not currently, no, but just to assure Paul that is being dealt with by the Adult Social Care Scrutiny Committee. So I think that's in the paper that's going to the next committee, because we had an update on pre-exposure prophylaxis at the joint committee last month, and I think Martin asked for further details. So I know Joe will circulate the papers, so it should be in there, because we've also been looking and obviously been concerned that we would see a drop off in attendance. So it's been picked up by a different scrutiny committee.
Thank you. Thanks, Sarah. Mary, you've got a point to make about pharmacies, and then Steve's waving madly.
I've got a general comment that if there are any instances where a person has an issue on the committee or someone they know, if they could get permission, we would investigate those issues immediately, because that will test whether or not there is a process we need to uncover and sort out, or whether there's a rationale for that particular decision making. So please do come through directly to Pals or to Becky or to Andy, indeed, and we will investigate as long as the person's given permission. That's fine.
And we'll now take, thank you, Mary. We'll now take Steve Lydon, Dilys Neal, followed by Andrew Gravells.
Yeah, unfortunately, this is the only place I think that there was scope on the agenda to raise this, although I did want it as a specific agenda item, but I'll be as brief as I can. 12 months ago, we had the Cheltenham Festival rating, and I think many of us who were on the committee at that time did raise a lot of questions about how, what and why it took place and what the cause and effects were. what was the risk assessment, what relationships there might have been between members of the jockey club and various powers that be. And I'm pretty certain at the time we were told there would be. It wasn't really germane for us to look at it. There would be a national inquiry looking into this to come back and feed back. Yeah, other than press speculation, I've seen nothing. And I did, the only formal process, of course, was me to request their task and finish group be set up via the county council, which some of you know is a torturous process and doesn't seem to be appropriate. So I just wonder, Chair, via you, if members are happy, we could actually write to NHS England to say what, if anything, did take place. Are there any findings? Or could we actually ask that such an inquiry takes place? Because at the time, it did cause us a lot of consternation, and we do need to learn for the future how things like this did occur. I know it's 12 months ago, but it's still certainly at the high on the agenda with many of the people I talk to and work with. What happened? Why did it happen? And what are the lessons learned?
I think a letter to I think a letter to NHS England would be very apt. Does the committee agree with that action? Will you stick your hand up if you do?
Sorry, Chair, I'm not agreeing. I just want to
stick your hand down there.
Well, I want to raise a point about the question. I'm not sure NHS England is actually the right body. I think it probably should be Public Health England.
Okay, Sarah,
it's polished anyway.
Yes, Public Health England it is.
I'm
declaring interest. My wife works for Public Health England. I'm not trying to generate work for her.
I was just about to say exactly the same thing. I don't think it's within the gift of NHSE to answer this question. Equally, I'm not quite sure it's entirely within the gift of PHE to answer the question. But in terms of gathering evidence, then I think you could certainly ask PHE the question. But I think also that I don't know that we ever committed to doing a review or an investigation into the races. Some of this, I think, as we said, and we've answered numerous council and cabinet questions about this, was out of our hands, and it wasn't a decision for the county council to make. But PHE would be a good place to start. I think some of the questions are national questions.
Well, can we not write to the minister as well? I don't mind who you write to.
We will write, Steve, and we'll hopefully get some answers. Thank you. Who is next? Andrew?
Thank you, Chair. I don't want to revisit the previous item, Fit for the Future, but I think one of the things that surprised me about this meeting this morning, given that I haven't attended a HOSC for 4 or 5 years, is the number of times people have said, what exactly is the remit of this committee? And we've heard that from HOSC members, and we've heard it from some of our colleagues in the NHS. So I would have thought that a very clear and concise statement prepared by our legal teams, or maybe together with Sarah, on what the role of the committee is, what its powers are, because it does have serious powers, and well, basically that, what its remit and what its powers is, so that we don't have people asking again, can we do that? Is that within our remit? And then colleagues from the NHS saying, not sure that you have that ability to request that. I think there has been some confusion this morning. I don't think it's helpful, and it's relatively, well, it's not relatively. It's the first time I've ever heard people talking about their confusion on the role of this committee. So I guess, Chair, sorry, I took a long-winded way of saying just some clarification, please, for everybody involved.
Through the chair, I've got the terms of reference here. I'm sort of not familiar with how the induction programme commenced with the committee. I've got the HOSC terms of reference in front of me, but I think you've all members have seen those and received those. I don't think it is the terms of reference that's the issue. I think it's the interpretation of the terms of reference.
Well,
so,
either way, Chair, there is confusion, and I'm surprised that the number of times that's been mentioned this morning, or this afternoon as it is now, by both members of HOSC and by our colleagues from the NHS. It's not a good position to be in. And, you know, some clarity, more than just what we're giving new members on induction training, just a clear statement of what we can do. Certainly when I chaired the committee, we didn't hesitate in going, for example, to the reconfiguration panel. Becky might remember that. And we do have, well, the committee has some serious powers and abilities to take certain courses of action. I think we just need clarity around that. I don't want to say any more, because otherwise I'm just repeating myself.
Okay, I will talk to Joe, talk to Becky, and we will send out a guidance note for what the powers of this committee are.
I think Becky's just reminded us that there is a detailed document, local authority health scrutiny guidance document that I think members have had and received. I will certainly circulate those again with the terms of reference to give some clarity. I understand, Councillor Gravels, that you've not been on the committee for some time, so I will circulate as much information as I can with the guidance. Thank you.
No, with respect, it's not just a question of me not being on the committee for some time. It's a question of me picking up what I've heard people say today during the meeting.
I've noted your comments. Yeah, absolutely. Absolutely. I've noted your comments, and it's not just your comment, Councillor Gravels. I appreciate that other people feel the same. I will send out the information.
No, that's really helpful. Thank you, Chair.
Try and address that. Thank you.
Thank you, Joe, and thank you, Chair. Thank you.
And we have Dilys Neal next.
Sorry, I'm asking this partly on behalf of my colleague, Councillor Andrews.
It'll be a complicated question then.
And it's to do with the ambulance service. And I've sent to Joe already this request, but could we have a look at sort of the way emergency calls are dealt with as a whole, because there are other people who are involved. For example, the community first response team. I'd love to know a lot more about them, how many there are, what their training is, what the recruitment process is, etc., etc. And I wondered if that would be something that could be included, maybe together or separate with the ambulance report. Thanks very much.
Thank you. Yes, we'll make a note of that. And in the past, we have made visits to the control centre in Bristol, which maybe we'll while doing again. Thank you. Do we have any more points people wish to raise?
May I come in, but it's not raising. I might go backwards here. I know with the ambulance service and everything else, when you get admitted, and especially this last year, there is quite a wait outside before you go in. And sometimes, and I know you've got to wait for a bed, and the bed manager got to make sure there's beds for you. And apparently someone was admitted the other day, and they were waiting 15 hours for a bed, which they were moved to Ward 5, I think, with pancreatitis, whatever. But I don't know how we can solve that. And perhaps when we think of new plans for the hospital, we need to make sure these people are not left in corridors or where there's a space to put them, even in the A&E. When you're admitted in there, you know, there's beds everywhere, and then the paramedics are bringing people in and taking them. It's like a shuttlecock in there. But you can't moan because we're all in their hands. Where I'm leading to this is, unfortunately, yet again, I had another little spell in the hospital. And I got to hang my hat up because I think I got to give them 15 out of 10. Everything was spot on. If I'm allowed to say this, am I, Chair?
Yeah.
It's crazy. And from the time I had a fall, and I went to run for the phone, slipped, broke my hip. Up, down. But and I went, and fortunately I had a strong, lovely man pick me up, and I knew something had gone wrong. I did have to wait a time for the ambulance, but when you're in a situation where you think you're going to get help, I said I didn't want an ambulance, but obviously I had to have one, and it started from there. And first person, they talked me through it before they came, and what was good was I did know the paramedics, and from the time I entered that hospital till I come out, I think I knew everyone in there. But anyhow, I got to there and I had to wait to go in, and I wait an X-rays, and I had to go back and have another X-ray, and then I was admitted to the ward, and I just cannot thank them enough. And everybody was so kind, and they made sure your date of birth, everything kept coming up and over again. It's all like a rehearsal. Everything was explained. And those nurses, and there again, I was very lucky to know some of the nurses on duty.
Thank you, Pam. Can we rush along? Sorry.
So where they how they work, you know, and they seem to be there day and night, and then go home. And I watch you do rest, and also and going to the physios. They were all excellent too. And from the time I left, and I got to say, I'll go 11 out of 10 for food. The food was excellent.
Thank you, Pam. Thank you.
I want to just say thank you all for the NHS.
Thank you.
I think they got it right, and God bless them all. May it continue.
Anyone else got their hands up? Andrew?
Yeah, just very quickly. There's been some fantastic work done between the county council and some of the district councils around housing issues. And I just wonder if it's worth looking at some of the joint working that's been done between the two tiers of local government in Gloucestershire, getting examples of good practice, what's worked, and learning from it, and understanding how we can do more of that kind of work. Because I certainly know within my own area, within the city, the cooperation between the city council and the county council has been at an all-time high, and both sides have benefited from that. So I'd be interested to know what work we can do to learn from that, to improve on that, and to address any issues which need addressing. I think there's some good scope there for us all to learn, both from the health side and housing side and other allied services side. Thanks, Chair.
Yep, that's on the list. Andrew. Well,
sorry, Chair, can I just, sorry to interrupt, but I think some of that work has been picked up under the Adult Social Care and Communities Scrutiny. So the work around homelessness has already been reported there, and certainly that those reports can be shared with HOSC. But I think we just might need to be careful around duplication and the demands on officers' time.
Indeed, yeah.
So we have, I mean, a lot of the work around community and accommodation-based support has also been reported to the Adult Social Care and Community Scrutiny as well, and the reports are available for members if that would be helpful.
Okay, thank you, Sarah. Thank you. Thanks. Well, that could bring us to the end of not only the current committee, but the 4 years. Although Steve Lydon waving on you there. He's waving. Steve.
I was just saying cheerio. I thought you were going to wind up. I was just saying goodbye.
I am doing. I thought you. Yeah. Not only the end of the meeting, but the end of 4 years worth of this cycle of HOSC. There really has been some fantastic good work done by the committee under previous chairman. Unfortunately, we've got to think about the memory of Roger Wilson, who was the chair of this committee for some time, and we do regret his passing with great sadness, followed by Carol Alway Martin, followed by Brian Robinson. And we had some strange news this morning. Councillor Lydon has decided not to stand in the forthcoming election. So all the best to you, Steve. You've been a great character and a great contributor to the committee. Well done and thank you. Now, just one last thing.
Best of luck for the future. There you are.
Pardon?
I said best of luck for the future.
We'll need it. The hospital charity, we've given you a broadsheet on that. The green spaces appeal, we'll have to look at that and see how we can assist that. It's the theme of a dandelion, I'm told, playing an integral role in the design of the garden. Every name a person for which the trust relied on during this COVID pandemic and will continue to rely on for some months ahead. So thank you all very much, members, for your efforts in past meetings. It's been utterly enthralling and interesting, and I think we have made a lot of progress.
Thank you, Chair.
And so thank you and good day.